And I've seen that.
Still in one piece.
That doesn't look like a lot of fun.
Good morning. It looks like we're about at the top of the hour. I just want to let everybody know that we are now live streaming on YouTube, and looks like we're good to
We
go.
are not getting enough volume.
And
I can,
kind of a
we
funny
need to-
story, you know, some of the pharmaceutical reps have come around and
that might be too loud. Ashley, can you, speak so we can see if our volume's high enough?
just a minute.
Yes. Good morning. Can you hear me?
We can hear you.
Office listens, and he's got to do big things. And, yeah, so he got about, and, the
All
strut.
right. How's the sound?
Got loose and it went like.
So
the valve didn't
I
go
did
back.
wear my hearing aids, I'm screwed.
And so, your options are.
That was stupid of me, and I knew
Put in a new.
you probably have your
Oh, valve. Or.
when I was leaving the house.
The electric or the.
I don't want to hear it.
Right, which I don't
I read all the comments and I was going, geez.
The decision of how big a strut to put in there, kind of like.
Okay.
These are those that have signed up for
That
that.
looks about right. And they, so
Good morning. How is the sound now?
Well, we're pretty good on the speakers here. What we really need is to have, some type of
Boom, I need to go. Well, it's not their own
speakers that are tied into this system that go to the back of the
The
room.
way they do it is they put.
You know,
Okay.
I mean, the commission can hear and understand, but the folks that are here cannot.
And see if it, so he went to Cleveland.
So I don't know what the capabilities are to do that.
In Paris.
We kind of talked about that before, and that is definitely something I'd like to, try to remedy.
Okay. Absolutely.
Sorry, but we're trying to like get everyone to quiet so they can hear.
Okay. Okay. Are you ready then? Is our moderator ready?
Yes. Good morning. Yes, we're all ready to go.
Okay. In that case, I will call the meeting to order. One of our commissioners is busy for a second.
Actually, 3 of them.
Actually, yeah, we're short.
Are you gonna be a minute? Do we have to wait for some other people?
Well, don't have to, but, I guess we better get going. It should be a longer meeting today.
We need more chairs?
Where, yeah, Katrina can take care of that. Let's-
Yeah. 1 minute.
1 minute, please.
And we need this.
All right. Well, while we have this minute here, my name is Ashley Anderson. I'll be moderating the Zoom and YouTube portion of today's meeting. Just as a reminder, we will be recording today's meeting and it will be posted to our YouTube channel for later viewing. If anybody has any questions, please feel free to email us at publichealthidaho@phd3.idaho.gov. Or if you are attending the Zoom meeting, please use the chat to interface with me if you have any issues that you need to troubleshoot. And I think with that, I'll turn it over to Commissioner Elliott.
Okay. Kelly coming back in quickly, or?
I think she was on the phone.
Okay, all right. Would you lead us? Okay, I guess we're ready to get started here now. So I'll call this meeting to order. And to start, would you please join us in the Pledge of Allegiance? And Commissioner Dale, would you please lead us in that?
Be honored to.
I pledge allegiance to the flag of the United States of America.
And to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Okay, for the roll call of the members of the board, we have Commissioner Dale.
Here.
Dr. Summers.
Here.
Commissioner.
Here?
Birdie is here in Georgia, and
Here.
Kelly's taking a call, and I'm here.
Commissioner Marvin.
And Commissioner Nate Marvin. I heard him on the phone. Very good, thank you, sir. Okay, okay, our agenda has had one addition, which is just the summary of changes to health alert level metrics and the mitigation strategies that needs to be added. And where would you like that added?
Commissioner Elliott, I'm sorry, that item is already on the agenda.
Oh, it
It's
is?
just an
Oh, okay.
attachment that was to accompany it,
Okay.
and that's
All
the
right.
last action item on the agenda.
Last
Yep.
action. On the health alert update?
Yes, sir.
Okay. Okay, so this is nothing new, just,
Right.
okay. In that case, is there anything else that needs to be added or changed on the agenda? If not, I would stand for a motion to approve the agenda.
So moved.
Okay, do I have a second? We have a motion and a second. All in favor, say aye.
Aye.
Okay, thank you. Okay. Folks, today we have, several guest speakers. They are informational only, basically not for a question and answer period, because we'll be here till tomorrow morning, at least. So, I would appreciate it if you would listen to them. If you have questions, I guess, put your questions together. Maybe they'll, maybe, I'm not speaking for them, give you someplace where you can send information or questions or whatever to them. Possibly they can answer or will or won't, or that's up to them. Okay, we just have them here today for information for us as board members. I will allow the board members a short period of time for questions or clarification if they wish. I wish we had a little better speaker system. That's something we're going to work on. I know here in the back of the room, it's really hard to hear. Some of us are probably, don't project our voices as well as you would like. So I know it's hard to hear, but if you would, please, I guess, turn up your hearing aids if you have them, and, you know, we're not trying to not let you hear, but it's just kind of the way it is right now. We do have a short period of time for public input. For the public comments, we received a pile, most of that there, of input this week. And I guess that's all available.
I would have to confirm with Katrina, who I think is in the back of the room somewhere.
Katrina, are those available online?
They will be posted to the website.
Okay. So you folks have availability to see what's been sent to us this last month, basically. Been quite a few, and you can read and decide what you think about them. I'm not going to comment on them. So anyway, without further ado, we have, 9 people here that would like to speak this morning. And we only have because of the speakers, we kind of have a shortened time. So please be concise, and hopefully we can get through all 9 people before we get to a certain point, and I'm going to have to cut it off if not. So to start with, Susan Lang.
Hi there, I appreciate you taking public comments and considering what we have to say or what I have to say. I'd like to know when infectious disease became the sole organizing principle for our entire society, such that our freedoms could be limited by public servants and elected and appointed officials. It seems like chronic disease is going up as a result of some of these measures that are intended to address infectious disease, and that's a trade-off that I didn't choose. I'm not sure if you're choosing it, I have a son who's mentally ill, an adult son. He's severely depressed and suicidal. Because he's an adult, there's almost nothing I can do. His freedom is protected by law, which I believe is a good thing. My freedoms, however, and our freedoms are being impacted by the decisions that you are making in an effort to address infectious disease. So I think that the role of public health in our lives and government needs to be seriously addressed. I'd also like to talk about something that happened, I think it was 2 months ago here at the meeting. Several of us got up to speak about mandatory vaccines during our conference. In fact, I think everybody who got it said, don't do mandatory vaccines, they're unwanted, they're unnecessary, et cetera, et cetera. After we had spoken, one of you on the board, I'm not sure who it was, addressed that topic of mandatory vaccines by saying, and I'm paraphrasing, I don't understand why y'all were talking about mandatory vaccines since it hasn't come up. I think the reason we're bringing it up is preemptively, because let's face it, a year ago, who could have imagined that we'd be in the situation we're in now, that lockdowns would happen, businesses would be killed, depression like my son's that is directly being impacted and exacerbated by restrictions, that kind of depression is skyrocketing. Who could have imagined that? So when it comes to mandatory vaccines, if you truly have no intention of doing it, I would suggest that you all take an oath and band together as individuals and as a board here today, say, we will never in any way mandate vaccines. We will never mandate vaccines and then deny that we're mandating it and just, have some sort of arm twisting at the point of grocery shopping enforcement as we've seen with masks and so on. I would like you all to pledge here today that you will never in any way mandate vaccines in the jurisdictions that you have here. So that's what I have to say. Thank you for listening.
Thank you very much. Margie Baker.
I also want to thank you all for allowing us to have a voice in the concerns that is really surrounding all of us, the nation and, states. But the reason I decided to speak today, because I've been here several times and I haven't spoken, because I was very disgusted to find out that our state was put down, supposedly in state of emergency, and you can look this up, in Idaho.gov, that the governor actually put us in this position with only one COVID case. One. That's all. That's one COVID case. And then, that was on March 13, 2020, and then on March 25th, 2020, with only 136 cases of COVID. And those are cases, not deaths, okay, mind you? Cases. We can talk about cases and cases. The deaths is where you really want to see this issue. And I was so saddened and disgusted and disappointed in, our government that it put us in this situation where we're all now here to speak on our children, our grandchildren, our families, our elderly. I have, my folks are 80 and 84, and they're fearful. My comfort them, I tell them, you know what? Psalm 91, God will protect us. We can't be all shut down and be afraid. We have nothing to be afraid of. Yes, we're all going to die. We all are going to eventually die. But I'd rather die with dignity and integrity than being all, weirded out. And besides, I have spoken personally to many internationally doctors and lawyers who said this is all political. It's political. So I'm going to leave it at that. But please, folks, do your research. Please, do it diligently. And speak to your physicians all over the world. And vocally, I'll focus on those. And also, I just forgot to mention, nurses and physicians that are in this local area, you can speak to them. They're very good. And I've had many nurses say that many even medical staff, nurses and doctors are lying because they do get $39,000, maybe less, maybe more, but someone has spoken different numbers of dollar signs. And if it's reported as a COVID case, they follow the money. they get money if they report it. And I've had family and friends who said that they had to fight the system because they wanted to say that they had died of COVID when they actually had cancer and heart attack and they died. And so they fought. Some of the families and friends have done that. So we're being lied to by mainstream media, by government officials, and let's have integrity. Because you know what? Even though I might not know everything about you folks, the man that serves us, let me take this into consideration for all of our freedoms. Thank you so much.
Thank you.
Thank you.
Casey Baker.
I just have a couple of questions, thank you. Those of you wearing masks, are you sick?
No,
Then why are you wearing a mask?
because you're not.
Okay, I'm not wearing a mask because I'm not sick, and I'm getting sick. Masks are for people that are sick, so you won't spread by talking, or breathing, or coughing on someone else. They're not for healthy people. Doctors wear masks to keep them from contaminating a wound while they're in surgery, not keep patients from contaminating them. Thank you for your time.
Thank you, sir. Stephanie Hughes.
Hi, my name is Stephanie Hughes. I was an ER trauma nurse for 22 years. Just a quick reference in regards to his mask question. As a nurse, we would wear masks when we didn't get it from the patient, and he is correct. You do wear the mask, the surgeon does, so they do not cough on it. I don't believe in masks. But here's the question to the doctors on the board. Our governor decided to put us back in stage 2 due to staffing issues at the hospital. Is that correct?
That's my understanding.
Okay. So, I have a question for this board. I've been trying to find out the comorbidities of the patients who are admitted to the ICU. Cannot find any of those. The ages, the staffing of the hospital from last year to the staffing today, the capacity of the hospital, not to what the staffing capacity of the hospital, but the capacity of the full hospital. Can't find any of those. Every time I call the district, I'm told the hospital tells us. I call the hospital, they won't give me any information. So I'm asking this board, where is that information and why are those questions being asked? Because our state is being shut down or moved back to stage 2 based on a nurse staffing issue? You guys have had 8 months. They've had 8 months to get this together. So those are some of the questions I have in regards to that. I don't see any of the admitted patients on your dashboard. There's no comorbidities, there's no ages, and I'm told that no one's asking that, and the question is why. And are they being treated for COVID, or are they being treated for pancreatic cancer, or their COPD exacerbation, which is as common? And are we testing for flu? Because I hear that they're not testing for flu now. I mean, there's a lot of strange questions, strange things happening, and I'm just wondering why this board is not specifically asking, especially the doctors who are in the healthcare. Because as a healthcare provider that I used to do, there's a lot of things not being addressed. My brother's an ER resident down at LA at USC at the county hospital. They are treating their COVID patients, sending them home like that, with medications, with therapeutics. Bring them in, send them home. The people are asking to stay because they are so fearful of what the media and what the health industry has told them. It's not happening down there, and they see thousands of patients. When this was first shut down, in Los Angeles County, the entire ER was quiet. Nobody was there. So I would like some answers. I've been trying for months to get those answers, and I'm asking you, is anybody here on this board going to seek out those answers? I'm sorry, what?
No, I think it'd be through the health department. But I can tell you the emergency rooms send a ton of people out. They come to COVID. They don't have hypoxia. They're not hypertensive. They get sent home.
Okay, what about the patients being admitted to the hospital, the ICU?
They're sick. They
How
have
old
to
are they?
require,
Do they
that
have
I can't
comorbidities?
answer. Dr. Blue is gonna talk,
Okay,
and he is in the hospital. He is working in the hospital daily. Dr. Schulte works in the hospital. They are better qualified to answer that question than I am.
okay, and I would appreciate if the comorbidities, the ages of the patient, and if they're actually being treated with COVID, or do they just test positive for COVID? Big difference. Thank you.
Maybe.
Thank you. Okay, next, John Nunez.
I'm John Nunez. I live in Jim County, up in Ola, but I've been down here for the last 5 weeks. I help veterans, I volunteer, veterans who are sick. Some of them have surgery, eye surgeries and things, so I make sure they get their eye drops and do things because they don't have any help. And a lot of them are cranky, and so their families don't even help them. But I now work I'm a chef. I work at a facility, assisted living, and there's a lot of rules and stuff. Of course, I'm against masks. I do wear a mask in there just to protect because of their age. But I know a lot. I've been around the system for years and years and years. In fact, today I'm 62. So I'm here because we really need to look at what's going on. Because I know there's a lot of false positives out there. And deaths, especially deaths. I've talked to different individuals, families that have lost people, family members, friends, and from accidents, from cancer, a lot of different issues, but never from COVID. And it says on their death certificate, right at the end, COVID. This is the stuff that we're upset about, okay? And yet you're not stupid. I know you're all smart people. I really do. And I commend you for what you've been doing already for our area. But we really need to take a stand and make sure when it really comes down that the people, you guys, your families, grandkids and stuff, that we realize what we're really doing here. Because we're turning people into puppets. Veterans that I know, a lot of them are suicidal because they're locked down. And they're told to wear masks. They can't even go to get their phones fixed. I've actually been live with them, taking them down, and they won't let them in without a mask. And a lot of them can't wear masks because they suffer PTSD, all kinds of different things. And they literally break down and cry. And, it hurts me inside that I'm seeing this. So please, use your brains, because I know you all are very smart, and make sure that we do the right things for the people, okay? Yes, there's a virus. There's been flus, there's still flus, there's colds. My family has a cold right now, so I'm not around them. I haven't been around them for almost 5 weeks now. So we need to really think about what we're doing out here, okay? And God bless you guys all, and I hope that all of you stay healthy. I seen you in Payette when I was there, asked things for voting. So things are coming, you guys. It's not going to get better. It's going to get worse. So we have to stand for us, for our freedom, and everything that we do. Because if not, we're going to lose out, and we're just going to be locked in our homes. It's not going to happen. I fought too many years, drugs and all kinds of wars with things that I did. I am not going to allow this. And I know that the people aren't either. So we're here to protect you too. We really are, more than you know, okay? So thank you very much for everything you do.
Thank you, John. Sean Alex.
Thank you for the opportunity to address you as a group this morning. My name is Sean Alex. I work as a firefighter paramedic in the field, and I actually work in Western Washington, live here in Idaho, and commute. So therefore, when this thing first took off, we were in one of the epicenters. And what originally came down with the virus, the numbers, the talk of having this exponential growth, the overwhelming of our hospital systems, of our ICUs, all these things that were mentioned, what turned out to be is none of that happened. what we did see on our 911 systems is that we had a 40% drop in our call volume, a 30% drop in our regional hospitals, which is the busiest in Pierce County, southside of Tacoma. And so as we go along and into the medical field, we have to research, we read papers, and that's what I think the public is so frustrated today is that anybody can go online, you can do your research, you can read papers on, on various, medical sites on past diseases and even this current disease. So when you see, like it was mentioned earlier by the nurses, that, well, where are the comorbidities? And you find out these people with like 65 plus with 2.6, 2.8 comorbidities that make them susceptible, which would make anybody susceptible at that age group to about any disease. What we don't find is that when we look at the death rates, or what's considered death rates, the CDC even put out that it was 6%, and we were about 167,000 at that time, was actually from dying of coronavirus, not a positive test. And so when people see that, they start to lose trust and faith in the system that we have in place. Along the staffing hospital question, what we found out is there was great layoffs across the country because a lot of the elective surgeries that weren't being done at the time, they had to lay off staffing. At the same time, people were scared to call 911 because they're so fearful of the mask issue, of not the mask issue, but the disease issue. They didn't want to be around anybody. So there's a delay in care when it came to cardiac, stroke, and other diseases. And so those are real issues. And so we have this epidemic of fear. And so now we don't talk about what is our hospitalization rate, what are our death rates from coronavirus. What we now talk about is cases. And what I find it odd is that here we have the inventor of that PCR test. It was never designed to be diagnostic. He said that before his death. It picks up fragments of partial, dead, or live virus, and it doesn't specify what virus. But then we talk about having an issue of cases. And so I think what this comes down to is that the more time goes on, the more the fear that sets in, it's causing great disruptions within our communities. It has a great effect on our elderly who are basically locked up in nursing homes. That generation should not have to be isolated. We know what isolation does to prisoners. And when you isolate these elderly away from their families, away from congregating together, that destroys the mind. We see what's happening to our young people across the country. We have a massive surge, like 30+% in suicides. They're not dying of coronavirus. They're dying of depression, hopelessness, and despair. And that shouldn't happen in our country. And I guess what I would like to just express, and I know you folks you have your agendas and things to find out and follow, but we need to be looking not just at what is funneled down through us, but we all have to have critical thinking, where we look around at these various studies. We have countries across the world who have done these studies. Sweden is a great example. And when this quote-unquote second wave has come about, their numbers are even lower than those countries that have done these more draconian lockdowns. And we know that the lockdowns don't work. We know that the masks don't work. So when you look at the studies that show the rate of infections, right, the numbers, they trail the studies of the countries who have done the lockdowns and those who haven't, and it's actually those who have not done those lockdown measures who actually have fared better. I guess at the end of the day is that as far as our inalienable rights that we do have, those are not suspended for any health emergency or any emergency at all. Our rights are inalienable. They're not given to us by government. And so when we talk about our patient bill of rights that we have within our hospital systems to refuse care, to refuse testing, or just our natural rights as American citizens, those are being trampled upon. And I think the frustration is going to come up. Sir, are you wanting me to speed up? Is that what you're
Please, because I mean, we've got a time frame and you're going
okay,
on.
We're over our time frame already. We still have a bunch of people that have signed up.
My case would be this, is that you guys all have, as political folks who work on this board, you also have to look out for the rights of the population as well. And nobody has a right to trample America's constitutional rights. Okay? Thank you.
Okay, we still have 4 people that have signed up here. We're already way over. So, please, we'll go another 10 minutes, but that gives about 2.5 minutes apiece, please. And then we have to respect the time of our guest speakers and allow them to get going. they've got other things in life to do besides just come and talk to us today. Okay, next, is Dell Chapel or Chapel?
Chapel.
Chapel?
Yeah, not that fancy, just chapel.
All right. Want to get it right, that's
No,
all.
that's all good. I've heard it before. No, I'll make it really short. Everything changed when most people in here covered what I already wanted to talk about. First of all, they don't allow us to be here. We have the right to be here. We have the right to be here. You guys need to know that too.
You have the right to be here, you don't have the right to speak at this
Cool.
meeting.
Well, thank you for allowing me to speak.
Okay, thank you.
Yeah, thank you. And thanks for your service. I ain't trying to be a dick, so. What is this board, what is your guys' role? You know, I'll be honest with you, I didn't pay a lot of attention up until COVID. What is your guys' job? What is the role of this board? To make recommendations, or what is it exactly? That's a question. I'm a serious question. Because last time I was here, I asked a question about what does a mask do to my immune system, and I was kind of asking the epidemiologist, and I got no answer. I don't know, maybe there isn't an answer, but I'm confused on the role of your guys', what your role is, what's your job? Are you a resource for us, the people, or? I'm not the only one confused, am I?
I don't know if we're supposed to have a discussion or.
Well, yeah.
Do you not know what your role is?
Well, I will tell you that I think that actually nobody that came into this and was elected as a county commissioner expected to be doing some of the things that we're doing now. Personally, I would say the number one role of the board, this is my personal thought, and folks that's probably been in these positions longer than I have may add something to that. But number one, the board or the health district is basically mandated by the state to provide education and also certain other medical facilities. I don't know if that's the right word. But that's the health district. Okay, the board basically oversees the health district as far, mostly when it comes to the monetary spending of the monies that are put into that district from every county. Every county puts in a certain amount of money, depending on, well, there's 4 or 5 different things that all go in to make up how much each county puts in. But basically our job, the way I looked at it when I first started this, which has changed a little bit now, was to make sure that those monies were properly spent to get the best bang for the dollar that our citizens were putting in to this health district. And personally, I would still say that's probably the number one responsibility that I have, to represent my county, to make sure that those monies are properly spent. Now, how that is being spent has changed with COVID. We've had it's tough to get some of the business done that we'd like to get done for everyday services that need to be provided here. But still, I would say, sir, that's my thought anyway, as my number one responsibility as being a member of the board.
More on the budgeting side of things for you.
Yeah.
Mr. Chair,
Yes, sir.
I would add to that's very accurate. I would just add to that any major policy decisions that are carried out by the health district have to pass through this board.
Correct.
For evaluation and voting on that.
Yeah, and that comes from our personal thoughts
Right.
of representing our county to make sure that money is properly used. So, it entails a bunch of different things, but in the end, the main reason I believe that the board exists is to make sure that that Nikki's just not going on vacation to you know, to Belize or somewhere 8 months out of the year.
So you're
And
not-
she works hard.
So you're not really a resource for me as a citizen, just to call in and say, hey,
Personally?
well, no, as a citizen.
No, I mean personally, I'm not.
No, you're not.
Okay,
But we got doctors on the,
But the district is that.
so I can call up here and say, hey, what's my chances of getting whatever, you know? Where do I get a flu shot? Where do I do this?
Correct. Yeah, general, everyday things that normally happen, before COVID.
What's Region 3's current, hospital capacity?
I don't know
Would
that.
that be a question?
That
for
might be
you guys?
something that's addressed today.
What's the current death rate? I memean, what's the real death rate? And really, I guess the real question is, and then I'm done, is how long are you guys gonna continue to play this game that they want you to play? Because if you haven't figured it out by now, this is a scam. This whole thing's a scam. And as long as you guys in positions of leadership continue to play this game, this is gonna continue. And you guys are gonna be the first step in stopping it. We're gonna be the first step by coming in here and throwing a fit, but you guys are the ones that gotta do something. This is a scam. And you shaking your head and grunting when people are talking is very rude, sir.
It's very rude.
I'm done. It's very rude. But when you got your face covered up, it's easy to do that kind of stuff, isn't it? Rude.
Okay, got a couple minutes.
I'm done. Thank
Okay.
you.
Maggie Goff. Reader's Digest version. Please.
Yes, once again, thank you all so very, very much for, thank you all very, very much for allowing us the opportunity for respecting us. I'm blown away by the amount of respect that you give us and what you allow. Thank you for also bringing in some guest speakers today so that we can have a diversity of experience and opinions from experts. Obviously, we've been seeing a lot of one-sided information, so I really do appreciate the diversity. I'm going to start by saying I agree with the CDC that if we're sick, we stay home. I agree with the CDC that if you cough or sneeze, cover your mouth, not with your hands, but some other means. I agree with the CDC that we need to wash our hands often. Hygiene is obviously very important, and that is where we part ways. The world is telling us our only hope, and they continue to tell us on every venue, our only hope is to hide and wait for the vaccine. And that is not our hope. Our hope, one, is in Jesus, but God gave us the most complicated, we are the most complicated biological machine. We have filtration systems, we have redundancies, we have an immune system. Everything about our design was designed to be able to resist stuff like this. And I have yet to hear anybody tell us how that we can personally ensure our health. So I would like to just say that for the record right now. Eat healthy, exercise, drink your water, get sun, get sleep, reduce your stress, reduce toxins, especially ones directed into your body, reduce anything that can come through the skin, reduce your fear. The Bible tells us 365 times to not fear, and I believe that that is because fear reduces the effectiveness of your immune system, and it makes us more likely to get sick. So that is what I'd like to say. I'd like to see telling the truth about how to survive COVID, and that is by doing what it takes to be healthy individuals.
Okay, thank you. This guy writes like me. Is it Tom Munn?
That's me.
Munn?
Yeah.
Am I correct?
Yeah.
Thank you, sir.
I'll do this as fast as I can. First of all, that's a military flag. According to Article 4, there's no pledge of allegiance to a military flag. We are under military jurisdiction, and you can check it with the United States Code because that's the law, okay? Not just some bureaucratic agency. Second of all, we're not a democracy. We're not a government by bureaucracy. We're not a government by corporations, and we're not a government by nonprofit, okay? That's not the way it's supposed to be. We are vastly becoming that way because the average American is ignorant of our form of government. Even according to Article 11, Section 8 of our state constitution, it says specifically that corporations cannot infringe on the rights of the American people. If you have not looked at that on your state constitution, please do so. Most of the time, I've sat back and I've watched this thing and I've been denied, people have been denied public comment. There's been this animosity between the doctors and the health departments and the people. And I have to say that you are so compartmentalized in the doctor side of things that your periphery is so narrow, you're not seeing the big picture. So I'd like to be able to help you understand that. The next thing I want to say is that policy is not law. Policy is administrative. Policy is created for you. It's not created for us because we don't get the benefits you get. So why would you pick and choose policy for you and pick and choose policy for us? In addition, mob rule, or we're not a democracy either, where the majority that is freaked out from watching liberal media or people that are hell-bent on passing the agenda, we have the authority as the minority to be able to stand up and righteously and indignantly exercise our freedom. And I'm going to say there's nothing you're going to do to be able to stop me from exercising mine, even if you're a doctor. I've been shamed by misinformation by college kids that are telling me that I'm spreading, okay? I'm listening to the media when I go in the morning to the gym, and it is pissing me off beyond total belief about all of the propaganda that's been going on. It is absolute BS from the way it goes. The interesting thing that most of you don't know, because I study conspiracy, yes, conspiracy, like election fraud, like COVID, okay? You can deny it all you want because you don't know what I know, just like I don't know what you know, Doc. Population, the control of the population is part of Agenda 21. Zero economic growth is part of Agenda 21. Collapsing the economy is part of that. Moving people out of the rural areas into highly densely populated areas is part of that plan. And everybody that's implementing these master plans is part of that. You can think I'm a radical tin hat conspiracy theorist, but for the last 60 years, our organization has never taken the wrong side of an issue. The other thing to consider is you start mandating vaccinations and you're going to start a war, okay? People are going to die against that. And I know that it's coming because that's Bill Gates, that's John Hopkins, and that's Fauci's program. They're all programming people, and anybody knows about how the TV ends up doing that is the one that realizes that we've been propagandized from the word go. Are you having fun yet, Doc? The other thing, too, is I'd like to be able to have somebody show me the hospitals. Take me to the hospital, Doc. I'll risk it. I'll even risk a 14-day quarantine. You take me throughout the state, you show me those hospitals, and you show me how overwhelmed they are. Right. The other thing, too, is I'm watching the news and it says positive. I listen to Maggie O'Mara. It says positive and probable. Are you kidding me? Positive and probable. What is that designed to do? That's designed to fudge the numbers. Not only do we have false positives and we have false negatives, we have all kinds of misinformation. First, Fauci says masks work, then he says they don't work, and then you're trying to tell me that you can wear a mask and you should wear that paper mask longer than 10 minutes when it was only designed for a sterile environment. I mean, you don't have to be a doctor to know that. And imagine the petri dish that's building up behind you right now. Nobody's mentioning that. You're endangering people, and the other part of this, too, is we're suspending the Constitution, the state Constitution, the federal Constitution, the Bill of Rights. We're suspending common sense, all in the name of something that nobody's challenging. Not a government, not a corporation, nobody's doing that. And you know what's funny? We're a government by the people and for the people, and it is our job to be able to hold government accountable. So don't you think for 1 second that you could pass your BS administrative policy on us and the fact that we're somehow going to take it. I am thankful, however, that we have questions from our commissioners that are recognizing the fact that there's a lot of misinformation here. So I will give kudos to our commissioners that are really trying to be able to go in and learn a little more. But there's a lot more going on than you realize. And all I want is the opportunity, like we do, to be able to share the information we have, because if you really care about being an Idahoan, you'll look at both sides of the issue, and that's all I have to say. Thank you.
Okay, last person, is it Brock Taylor? Brooke.
So hopefully I'm in the right place because my comments are somewhat different. I am representative of a large group of NAPA parents who we want our kids in school. Seems kind of crazy, but they all want to be there too. So we have been doing our due diligence, trying to work with our board of trustees and hopefully Southwest District Health, calling in and just trying to get answers because the governor has expressed that a lot of money has gone into opening our schools, and we've got proven numbers now that cases don't really spread in our schools. And it's causing a lot of problems in our community. So I just have questions, I guess, because we're trying to figure out where to go as a parent group because our kids are our most valuable asset. Of course, as parents, that's how we feel. Sorry, don't mean to get emotional. I'm just like a little overwhelmed at the moment. So my first question, and I really just have to ask at this point because no matter what is said or what goes over in our board meeting, we're constantly hearing from the hospitals. That's all we hear. And for us as parents, this isn't an apples to oranges comparison anymore. We understand that there's a lot going on in the community and that you guys have a huge job. Our piece really has to do with our kids are being failed by the plans that are at play. And we're trying desperately to find ways that we can work together with the community. So we now just have concerns, and questions, just a lot of questions. And even though we call the health department, and I understand why it probably gets to be very overwhelming because there's thousands of us, because we have children. But the first I have to ask, and I printed this off today, is it a conflict of interest that Nikki is with Southwest District Health, but also on the board of St. Luke's? And I just have to ask, are these, these are real questions that parents have now. So I have that here, and then the other thing that I have to ask is, do we have a way to stop things like these tweets from, he was from St. Luke's, but now he's on the governor's task force where he asked for pictures of our children if they're not compliant. And I brought that to you guys, but just because. What? Again, I wasn't trying to, I have questions and I don't know where to get them answered. I'm just concerned for our issue. So as far as everything else goes, I know that there's a lot, and I don't want to add any more to what you're trying to say, but my issue is super specific. Like, these are just concerns that we truly have, because we don't want our kids labeled, right? If my son's not wearing a mask, I don't want a picture of my son going somewhere and have him being labeled as something that's not going on in the school. It's concerning as a parent, like, it's terrifying, to be honest. We believe that everybody is important. We know that you guys have a lot of issues on your plate. This is huge to us, and it's causing such distress in our community. There was even a protest last night by the teachers totally misleading, like what was happening wasn't even happening, but that's where we're very volatile. So we're worried about the whole thing, right? Like, we want our kids to learn, but we want them to be safe. We want teachers safe. Like, we really are a concerned group. So I brought backup information for everything that I needed to address. I felt like that would be really helpful, coming more as a concerned parent for what we can do, knowing now that spread is relatively contained in the schools because we can't control the communities, right? Like, that's the pushback that we get. But I've got a parent who has COVID because she was forced to go bury her mother who died 8 months ago and they could no longer keep the body and she contracted COVID. So even if we're doing our part, right, and we're trying to get the numbers down, it can't come at the expense of our children when maybe school is the safest place, because it does keep them from wanting to go places, because when we're picking them up, they are having mental issues and problems. We have multiple parents who have medicated their children because they're not handling this well. When it doesn't seem like that necessarily is the right answer when we're proving, and the governor has said that we've invested millions of dollars to open schools, right? So I have to ask now where the conflict comes from, because all we constantly hear is from St. Luke's, and that Southwest District Health is keeping us in this state, with the schools, and then it comes back, and then the Napa School District says it's Southwest District Health, and then again we hear from St. Luke's. So now we're really just looking for connections. There's also somebody from the school board or the school affiliation on this, this board for St. Luke's. So we have to ask them for questions. So you might not want to touch that, but that's the committee. And then these are the tweets from that doctor where it shows that he is asking for pictures of our children. Thank you again for your time. I really do appreciate that you guys are in a hard position.
Okay, thank you very much.
Thank you for letting us.
Yes, thank you.
We, believe it or not, we appreciate information. We know we don't know everything. We're trying to do the best that we can, and information helps us be able to do what we have to do as far as making decisions. So thank you very much for your time and your input. Again, I would remind you, please be quiet and considerate during the speakers. And again, we're not going to allow questions to them right now. So, but thank you very much. Appreciate it.
Thank you.
Okay. Whoa. way behind schedule. All right, our first guest presenter, Dr. Vicki Wool.
So, yeah,
Okay.
Dr. Wool, if you want, there, you can come sit here, and then, Ashley has your presentation.
All right, just a moment, please. I'm getting this all set up. Thank you.
Sir, do I have 5 minutes, 15?
No, you get 15.
Okay. I will try to fight with it. She said,
Yeah, that's what we've tried to do, is give everybody 15. Fair representation.
So please let me know if you cannot see the current slideshow.
Dr. Wool, that's actually a recorder, Ashley.
I'm gonna need this.
Ashley can forward those, or you can just prompt her to do it. Does that?
Really? Not really. Is there any other way I can do it? Next.
Yes. Ashley, we lost the presentation.
Okay.
Well, we're looking at a very nice picture of you, so, I mean.
Apologies. Is this the correct presentation?
Yes.
Okay.
There's no way that I can control.
Just say next, I
Yes.
guess.
Thank you. Well, listen, I really appreciate you letting me be here. I'm really here for you, and I want to give you some hope, okay? I also want to say something else. I'm available to speak. I have a long presentation. I won't be able to get through it all. I've got a lot of data, information, and connections. Thank you. So who am I? I am a physician, and I'm also an epidemiologist trained at UCLA with actually a professor that was the chief of...
Now, Vicki, yeah, you're really here for us, not for them. So, please, I wish we had, is there any,
Back a little bit, you might be able to.
do we have any other
introduce
microphones?
everybody. That's okay.
I'm wondering if she's up here and we just kind of move back, because that way she's talking to everybody.
Okay, if that works.
That's fair?
And, I know everybody projects their voice different, but, go loud if you can.
Loud.
It's hard. Can you hear me?
Yeah.
Okay, sorry.
All right, thank you.
All right.
Now we'll start the 15 minutes. We're not cutting you short.
Thank you. Okay, so I'm a physician and an epidemiologist. I was trained at UCLA. My professor was the chief of CDC. He discovered a new virus in India, so I kind of know what I'm talking about. I've been in medical politics for about 15 years, and I've watched the destruction of medicine over those years. I've been in 6 years in the Ada County Medical Society, in the Idaho Medical Association, and the American Medical Association as the alternate delegate for Idaho. There are 2 doctors that represent Idaho to the national level. I was one of them for 6 years. Also the Independent Doctors of Idaho, I was on the board there. Also with the National Physicians Council for Healthcare Policy. Now currently the National Healthcare Coalition, which is a group of grassroots physician groups that are really interested in the truth. I'm not owned by anybody. I don't work for a pharmaceutical company. I don't work for anybody except Jesus. So my colleagues are going to present to you what I'm going to present in terms of the hope on Thursday to the Senate in Washington, D.C. So there's a little story here that's really very interesting. I lived a communistic takeover of a country for 10 years. All right? I lived in Venezuela. I went to medical school there. I worked in the clinics and the hospitals there. I know what I'm talking about. This is how it started. It was a frog in a boiling pot over time. So people became more and more dependent on the government. There was corruption. We had shortages. There was price control. Everybody was asleep. We didn't understand what was going on. There was increasing poverty, unemployment. We had encapuchados, which were these guys that were dressed in black at the beginning of at the opening of the university, throwing rocks, shooting gunfire, and, I had to walk through tear gas numerous times to get to classes. Then the coup happened, and that was Chavez. You just heard about the election fraud. Well, it all started in year 2.
After the coup, Chavez, he bombed the center of the city and everything stopped. I hitchhiked to a free clinic and during that day saw looting. I worked all day, all night. It was incredible. I was actually outside a prison that's called the Retenn de Casia. And the Retenn, as I heard, now that I know what was happening that day, the police were inside the prison shooting the prisoners. The banks closed. We went into martial law. The banks closed. There was fear. The police were very scary. It was a police state. There were 3 types of police. People ended up missing. There was a whole building down the street where 5,000 people supposedly had just been turned. Their bodies were turned in there. They started turning the water off on us. They turned the electricity off on us. We couldn't go outside before 7 in the morning and had to be back in the house by 7 at night. In the hospital, you know how fun that was, trying to work without water and then even go to use a restroom or try to get an x-ray? We had to recycle our own gloves. So we'd wash our gloves in a basin and then we'd put them in the autoclave and then recycle them. So the supplies were short, it was all scarce. And in the end, we found out the government was behind all of it. I'm going to repeat that. In the end, we found out that the Venezuelan government was behind all of this. So I came back to the United States. I walked into a grocery store and I cried. Seriously. I looked at the shelf and I went, oh my gosh, there are like 10 different types of mustard. Really? So, and then the Lord said something to me. And he said, the United States has 20 years. Huh? The United States has 20 years. That 20 years was up in 2016. We're on borrowed time. And here we are. So what's happened to Venezuela in the subsequent 20 years? Hyperinflation to the point of starvation for many. The government came in and they confiscated all property. You didn't own any property. Your businesses were totally part of the state. They took land for cattle ranches, food production. They outlawed firearms, except for the criminals, they had them. They released the convicts, and then they relocated them into middle and upper class neighborhoods after evicting previously legal occupants. People had limited possessions, and everything became a ward of the state. Now they're in a permanent lockdown. For years now, people don't leave their homes, they don't go to sporting events, they don't go dining out. I mean, the inflation is, you can't even afford a chicken. It's that bad. But everybody's dependent on the government. So they don't have automobiles, and you risk even putting gasoline, if you can afford a car, into your car because everybody's got a gun. Long wait lines. I mean, so I can paint you this picture. It's not a place you want to end up. And you really think the United States is so immune? It's not. And you all see it, because you're all expressing something similar. So think about where we were 9 months ago. Did you think we'd ever get here? Well, there's more to come. So why can't we be attacked on our home ground? It's the only other place that hasn't been attacked since like 9/11 in 2001. We didn't think that was going to happen either. So what we're fighting right now is a war. It's unconventional, but it's a war. Our civil liberties are being sacrificed. We're fighting. We've got animosity towards every group. Truth is hard to find. And in actuality, folks, we're victims of very sophisticated psyop, psychological warfare. It's getting us through social media. We are not the enemy. The enemy is coming from without. So we need to get unified, we need to organize, and we need to start voicing up. Okay, so next. Please.
Next slide. There you go.
Okay. This basically says, I got a responsibility, folks, to share this information, because if not, the blood's on my hands, and it's not going to be that way. Next. So this is a home-based guide to treatment of COVID. And it's got a free website. You can print it out yourself, covidpatientguide.com. It's produced by the Association of American Physicians and Surgeons. I'm going to briefly go through it. Next. Coronavirus, as you're familiar with, we had SARS in 2002, MERS in 2012, and then we've got SARS-CoV-2 2019. Next. So symptoms that you're all pretty familiar with, runny nose, fatigue, cough, diarrhea, which a lot of people are talking about, chest heaviness, then you can drop your oxygenation, you get pneumonia, you show up at the hospital, and then you're probably, you're fighting for your life. Next. So high-risk groups that you've all heard about, well, you can't have diabetes, you're overweight, lung disease, kidney disease, hypertension, cancer treatment, all these things. Next. But the biggest number one is vitamin D deficiency. That's been proven over and over and over. If you've got dark skin, not like me, pasty white, okay, but if you've got any pigment in your skin whatsoever, your vitamin D levels are lower than not. That's why there's a preferential discrimination in who this is affecting. Elderly also. Elderly, brown and black skinned individuals, you need more vitamin D than a lot of us. Next. So, not to treat, since when? The NIH, CDC, our public health officials are saying, well, we don't treat as an outpatient. Well, since when? That goes against everything that we know. We treat against influenza, we treat against bacterial infections, diarrheal disease, and now doctors on the outside of the hospital system aren't supposed to treat? No, it's wrong. We need to treat, and there is hope. So, go ahead. So these are the 4 pillars of healthcare, or attacking, an epidemic. Stopping the spread, early home treatment, reducing hospitalizations and deaths, which is where I'm going to focus today. Late stage is the treatment for in hospital if the home treatment fails. And we've got great physicians that are working in the hospitals, saving people's lives, but you don't want to get this far down the road, and I'll tell you why. And then the last pillar is vaccination. Scary for a lot of us, but there are some other things you can do for prevention. Next. So, common sense, being careful with disinfecting procedures in the home, treat early, we have medications. I'm board certified, but I have a license. Medical licensed practitioners can prescribe any drug that the FDA approves. So this whole thing about the hydroxychloroquine has been out of control and crazy. We don't really understand. Anyway, next. There are 2 bad responses in this whole thing that I want you to pay attention to. One, there's an exaggerated inflammatory response. So if we don't treat early, what happens is the virus multiplies and multiplies and multiplies and multiplies, and then it triggers a cytokine storm, which is an autoimmune response in your lungs for one place that destroys the tissue. Secondly, there's a response where their blood clotting is increased. So you get these micro blood clots all through your system, both the arteries and the veins. This is what's causing a lot of the problems. So those are the 2 bad things that can happen if we allow this virus to fester inside of us. Now, what's interesting is, and in new information, is that there are cases of orchitis, meaning testicular inflammation. Is this leading to male infertility? So are young men going to be facing infertility in the future? Second, cardiomyopathy. There are some folks that are having problems with actually their heart muscle. Next. So this, in terms of a timeline, which also reiterates why it's important to treat early, you get your symptoms onset right here. About 7 days, you start to have your cytokine storm, and then you get your microthrombosis, and you can see as days go out. Most people don't even seek treatment until they're home. I had a young lady come into me, and she said, I have pneumonia. I went to the emergency room. They sent me home and said, if I can't breathe, come back. I said, oh, honey, I will so treat you, and you're going to be okay. And I treated her. She burst into tears. She had been so worried and so concerned. She was in her mid-20s. She was better within 3 days after starting treatment. But anyway, this is too late to start up here. Too late to start up here. We have to be able to get the people in their homes and then have, and move on from there. Next. Okay, so pillar 1, contagion control, I'll discuss this at the end. Next. Pillar 2, early home treatment. Next. So what are the advantages? I'll let you read those later. Next. Okay, so in general, which has already been said, just kind of general things. Wash your hands, get off sugar and high carbs, because as soon as you eat a high carb meal, your immune system gets depressed. Get outside, get some sunshine, breathe fresh air. You need that oxygen. Mask if you have a cough and you have to go somewhere, but if you're home, if you're sick, stay home. Contact online physician services if you're worried about COVID and your physician does not believe in home treatment. And that's the big concern that a lot of people have. Well, my doctor won't give me any medication. Find somebody that will. There are a number of us. Get information on 5G technology and don't upgrade your phone if possible. Studies are showing that there are many concerns. There are countries where their citizens are actually ripping down cell towers. We need to look into this. Thank you. Next. Fresh fruits and vegetables, 6 different colors a day. Get off the package, stuff that's already been processed over and over. Vitamin D, again, we're looking at about 5,000 units a day. Vitamin C, maybe a gram twice a day. Zinc is essential. And zinc sulfate is easy to find. You don't want to take too much of it. So these are only meant as a guideline and not prescriptive authority right now. N-acetylcysteine, which is NAC, that's a precursor to glutathione. Seems to be very important in what we're dealing with right now, so you'll want to look at that. Vitamin A, 200% of the recommended daily allowance. Magnesium if you're deficient, and a zinc ionophore. Well, what is a zinc ionophore? So this is what happens. The virus attaches to your cells through ACE2 receptors. The virus gets into the cells, it takes over the cell machinery, it makes a lot of viral load, and then you get the whole cascade. What's happening when you've got a zinc ionophore in zinc, the virus comes in, the sites are already taken up on the cell, so it's already competed. You get less virus inside the cell, but that zinc ionophore has allowed zinc to go into the cell, and it stops up replication. It stops the virus from replicating. So what are zinc ionophores? Elderberry, green tea, quercetin, but you have to take them daily because they don't last that long and you have to have the zinc inside the cell. This is all preventative. This is all before you get COVID. You can take hydroxychloroquine, 1 tablet a month. Why? Because the half-life is 22 days. Chloroquine has a half-life of 55 days, so you really could take a half of chloroquine once a month. If you're sick, the recommendation is take another hydroxychloroquine and seek immediate help, because again, the process of going forward. Next. Other things that are currently being used, we're using aspirin to stop the stickiness of the platelets, colchicine, steroids, both oral and inhaled. The oral, prednisone, dexamethasone, and methylprednisolone, like a federal dose pack. Inhaled, budesonide, cholesterol, for hypercoagulability, some of you that will know about bromelain and nattokinase. There's a group that's using quercetin and bromelain as a prevention. Oxygen can be prescribed at home, but sometimes the whole treatment of this is more like a waiting game. And then ivermectin. Ivermectin's been used safely for 40 years. Lots of vets have it. And so ivermectin is kind of coming in a line with hydroxychloroquine in terms of treatment. Next. So, stage 1. Stage 1 to 5, we use antiviral agents. So if you do get sick, what you're typically going to be prescribed to one of the docs is hydroxychloroquine with azithromycin or doxycycline, or ivermectin with azithromycin and doxycycline. You need the zinc. Again, you know why now. Next. Stage 2, anti-inflammatory. These are the steroids that come in because the inflammation damages the airways. And so we can nebulize the budesonide, we can give oral, prednisone, colchicine, aspirin, and then, again, oxygen if needed. Next. Stage 3, anticoagulant. So I've had a couple of patients that I've had to actually use Eliquis, which is a Pixaban, because their coagulability was so high, the patients do get better. They're starting to lag out, which is one of the things that we're watching. Next. This is what Peter McCullough, who is a professor at Baylor, came up with. This is what they're going to be presenting on Thursday. This is kind of slow in terms of giving you some direction. It's all, again, it's all in here. Next. And this is Zelenko. Zeb Zelenko, great guy in New York, who just, the media has just trashed him. But he ran a community. He saved hundreds of lives because of his protocol. And this is his protocol in treatment. Next. So, empower yourself. Take charge. Get your gut health good. Print out this. You know, talk to your family members. Get them on the supplements. And find a physician who's willing to prescribe, you know, hydroxychloroquine or ivermectin or something if you're higher risk. You don't want to just wait and see. And that's because you get into trouble. Next. Okay, that villainized drug. This has been incredible. Political acrobatics to discredit this. 60 million doses are on hold in an FDA stockpile somewhere. 2 of the 6 plants were actually burnt down and destroyed. The governor and the Board of Pharmacy have totally interfered with my right to practice as a patient-physician relationship. This is unheard of, absolutely unheard of. Since when can a pharmacist say, I'm not going to allow you to have that medication? You know, it doesn't happen. There's a bigger thing that's going on here. So, fake science. The Lancet and the New England Journal of Medicine, they both published articles saying how awful hydroxychloroquine and how dangerous it was. Well, they yanked those articles because they couldn't prove it after 2 weeks. But that was after those news stories went worldwide. They stopped some really good clinical trials, and lots of other people died because of it. It simply works. So in the future, there are a lot of people that are talking about, for those that have been in charge and are making these decisions, are they really crimes against humanity for the excess death? Next. So these are the websites: speakwithanmd.com, frontlinemds.com, myfreedoctor.com. Those are all online sources to get medical help. Next. So, cases have been mentioned. What's the definition of the case? We already talked about the PCR testing. You have to replicate the genetic material over and over and over again. They say 35 is kind of like the sweet spot to pick up positive. Yet the FDA says no, go up to 40 where you're getting more junk, and I think even Nevada is doing up to 45 cycles. So there's a lot of spurious courses. And the IgM and IgG are not routinely done anymore, which is part of the immune system, right? We've got the humoral immunity, and we've got the T-cell mediated immunity. Well, why aren't we testing IgM and IgG? That tells us how much disease there is in the population. Again, this has been manipulated. And T-cell immunity is largely ignored because it's difficult to test, and this is really important in kids. So when you hear things like, oh, kids don't have any immunity, you don't know that. They have natural killer cells, and they have amazing immunity. If you've had kids, you know that they're petri dishes, and you know that they get sick every 2 to 3 weeks, and then they bounce back, and they're totally fine. Why is this any different? Next. So these are inclusive data, WHO, for confirming a case. These are confirmed cases. Next. Probable cases, if you're just around somebody, really. Next. And these are suspected cases. All of these are to drive the number of cases. Next. So, what does it mean? The deception here on cases and cases. One positive case, if you guys and I go out and we test 100 people and there's one case that's positive, we have one case out of 100, right? One case out of 100 because we test 100 people, so that's 1%. But if we go next week, we go, oh, well, you know what, we've got more tests. We're going to go test 10,000 people, and we get 100 positive cases. Well, if you divide 100 by 10,000, you get 1%. This means all you hear is, we went from one case to 100 cases. Oh, wow, this is really dangerous. No, it's all dependent on how many cases or how many tests you've done. They're not, so when you watch these statistics and they just report cases without a denominator, you're being deceived, okay? And this is why. Next. So death rates, the same thing. It's already been mentioned. You know, we've got lawsuits trying to get COVID off of death certificates. I personally saw a coroner's report. 5 people died that night. All of them listed COVID as the #1 cause of death. But yeah, maybe they fell 3-foot story too. So, I mean, they were all traumatic injuries. So this is clearly something else is going on. I think we need to have a comprehensive review of death records to validate statistics that are being reported. Next. So, cite the science, please. The citizens of the United States are respectfully requesting that the science and reasoning be used and cited for criteria for pandemic, quarantining the healthy, shutting down the economy, neglecting other morbidity and mortality data, social distancing to 6 feet, and masks. And by the way, where is the data on fecal transmission? And why are no UV light treatment fixtures in place to stop spread? Next. So there's a real good article here, COVID-19 statistics and facts, meaningful or a means of manipulation, written by Kristen Held, who is the president of the Association of the American Physicians and Surgeons. Next. Number 3, late-stage treatment. Next. Okay, so now you can't breathe, you're in the hospital, you're diagnosed with pneumonia, and you're admitted. These are the important statistics that we know from our hospitals. The admissions, ICU admissions, COVID deaths with comorbidities, and critical, a friend of mine works at a critical access hospital in a different state. It's the busiest time of year for hospitals. Is influenza being tested? There's people have pneumonia, there's COPD exacerbations, MIs, stroke, cancer, motor vehicle accidents. And he said, you know, he just had to take care of a patient who's lost a lung because he has metastatic lung cancer, delayed diagnoses. So the hospitals are full this time of year, period. Next. So ask more questions. Many of the hospitals have closed wings and they furloughed their staff when things got skinny. They just let them go. So they may have report a number of beds, but that's less than their real true capacity. So for example, if this hospital had 437 bed capacity, but they only have staff to work 325 beds, then they'll say they have a 325 beds, but they really have 437. That is a 25% or difference. That's a lot. And currently, they've got 36 cases of COVID, which are 8% of the total bed capacity, or 11% of the functioning bed capacity. There are 18 beds in medical ICU. All of them are full, and none have COVID. So there's the heart attacks, the strokes, the cancers, the dropped lungs, whatever. And then 16 in surgical ICU. 10 of the beds are filled, 7 have COVID. Next. So if you want to know what's up with the hospitals, ask them for comparisons. What's with this year versus last year? Or how about the year before? You can start looking for trends. And just if you ask for any kind of financial data. And again, here's this article on where the money is. Next.
Dr. Wolf,
Yes, sir.
you're coming on 30 minutes.
Am I really?
Yes. So we need, you need to wrap it up, to make sure that everybody gets a proper
Thank
time.
you, I'm sorry.
Thank you.
Okay, I'm open for other talks. Obviously, I misjudged, I apologize. Thank you for your indulgence. But there are some comorbidities that you're gonna, we have, and other people brought them up. We have underestimated the suicide. Used to be that 18 to 24-year-olds would think about killing themselves, 10% of them, once a year, right? Now, it's 25% are thinking about it monthly. They're monthly, they're hopeless, okay? Drug, alcohol, excess, homicide, spousal abuse, child abuse. Child abuse, kids aren't in school, they're not getting picked up by the teachers. So, we have 42 to 66 million children falling into extreme poverty. And UNICEF warns that there'll be an excess of 1.2 million deaths. Go ahead, Nick. Drug and alcohol abuse, misdiagnoses, delayed surgeries, depression, anxiety, and I think what is so egregious, honestly, are the seniors that are in nursing homes and long-term care facilities that are failing to thrive. They're simply giving up. And as, grandma has her hand on the glass door, trying to, just all they want is a hug. Next, I think I'll wrap it up here. Well, there's 130 million people at risk of famine, there's economic ruin, closed businesses, so why are we accepting this new normal? Multiple lawsuits are springing up all over the country. Anyway, thank you very much. I appreciate your indulgence.
Thank you. Thank you very much. Much
Can I ask
appreciated
a
on the
question?
information. Yes, sir.
One easy question. So all the stuff you had, vitamin D, zinc, et cetera, are there double-blind controlled, placebo-controlled, peer-reviewed articles?
Well, that's where we have been tricked into this whole RCT. We're looking at a pandemic, we've got people dying, and we've got story after story after story of people that have turned around on a dime within 48 hours with these medications. So what happened?
That's hearsay.
No, it's not.
You've got to have a control file.
In 1987, 2 years went by that HIV patients were not allowed to have any Bactrim to prevent pneumonia, right? Because they were waiting on the random control studies. And I've got a lot of data, international data, that the United States has neglected the international data.
The answer is no, not yet.
Okay, thank you. All right. Our next guest presenter is Dr. Michael Carlfeld. Carlfeld. Okay. My mispronunciation, I apologize.
Well, it's an easy one to make.
Well, I should have had my glasses on. I thought it had 4 letters.
I'm going to bring a timer so that we have
Oh,
a clue.
well,
Myself.
thank you, sir.
So I'm Dr. Michael Caldwell. I run an integrative healthcare facility in Meridian, Idaho. And I do believe in utilizing all aspects of both holistic and medical, bring them together and success for all worlds. Next, please. Click or somebody else?
No, just say next.
He did say next.
Might be slow.
Thank you.
There's, thank you.
So, the focus, I'm not here to convince anyone, because I feel it's a convinced mind that's not really here posting information. All I'm wanting to do is to cast doubt on what we're dealing with. I'm wanting to highlight some flaws of the current testing, and also wanting to point out some of the ineffectiveness and potential harm of the broad policy of public mask wearing. So when you're talking about double-blind studies, these are things that we would like to see. And also in regards to the vaccines that they're rolling out, where are the studies? Also, highlighting some alternative treatments available, versus having a National Guard military delivery of Operation Warp Speed, Moderna, Pfizer vaccine that is not properly tested for safety with high potential harm. So in the medical profession. It's the first do no harm. And also, you always need to look at if the cure more dangerous than the disease. Next, please. So, so what does it mean when you're tested positive from the coronavirus? So we're using the PCR test, and PCR test is you can use it as a quantitative test, meaning that you can see how infected is the individual. And that depends on how many cycles you need in order to be able to find then the virus. So right now we're just using it as yes or no answer, which is not really that effective. So the PCR, what it does is amplifies the genetic material from virus in cycles. So again, the fewer cycles required, the greater amount of virus or viral load in the sample. The greater the viral load, the more likely the patient is to be contagious. Next, please. So here's the interesting thing. So they did it in 3 sets of testing data that include cycle thresholds compiled by officials in Massachusetts, New York, and Nevada. They have up to 90% of people testing positive carry barely any virus. So 90% of them have barely any virus. So what does it mean then to be testing positive if 90% of them barely have any virus? So one solution would then be to adjust the cycle threshold, because in some states they do up to 45. Most tests they are at 40, some at 37. So that means that you're positive for coronavirus if the test process required up to 40 cycles or 37 or 45, depending on where they're at. There's really no, I don't think there's been a standard that's been set from state to state. If whoever feels like they want to do whatever amount of cycle, that's what they seem to do. So what are we testing? So the test, what we're doing is that we're looking for genetic fragments. So these are leftovers from the infection, and these genetic fragments, we really don't know if these genetic fragments is causing any disease or if you're infected. I mean, you're finding the genetic fragments, but again, it's kind of like finding a hair in a room after a person's left. You're just seeing something that is there, the genetic fragment, but is that person infected or not? So again, 90% of people testing positive barely carried any virus. So CDC's own calculation suggests that it's extremely difficult to detect any live virus in a sample above a threshold of 33 cycles. So, also was pointed out priorly that a PCR test was not designed to diagnose disease. It was designed, the creator who, passed away about a year ago, was designed to manufacture. So you replicate genetic material, and it was designed then for manufacturing. Next, please. So what are the implications of this data that we are bringing forward? We have the 90% of people that think they are infected when they're not. So obviously we have financial, which is excessive closure of businesses and employee sick days. So people are having to call in sick because they tested positive. So now they cannot perform the duties, they cannot receive pay, impact their family, so it has a huge cascading effect. Educationally, talking about closure of schools, and that is a huge concern. What are we doing to our children right now? I mean, what kind of education are they getting amidst all of this? Medically, so now we are allocating excessive medical resources, towards this, instead of focusing on other medical care. People still dying from cancer, they're still dying from sepsis, they're still dying from heart attack, there's stroke, so these are things that are still out there that we need the medical profession to be able to be available. I mean, they play a very important role, and we don't want that part to be taken away. We need that. And then you have the emotional aspect. You know, you have the isolation, loss of community. You know, so increasing rates of depression that Dr. Bates was talking about, anxiety and suicide. CDC survey, and this is just focusing on one group, at the end of June, found 1 in 4 in age group 18 to 24 had considered suicide the last 30 days. 25% of our 18 to 24, this is our next generation to carry the United States, and they're considering suicide. So we're doing something wrong. Spiritually, you know, we're now imposing limitations on public worship. You know, we're limiting our ability to worship God. Next, please. So what is the current threat of COVID? So, and we obviously have dying from COVID versus with COVID. And and from my understanding, you have federal financial incentives to document COVID deaths. So, you know, I'm hearing stories, and I've heard the same. People dying in car accidents and was COVID on their death certificate. I've had cancer patients that had to try to argue to get COVID away from the death certificate. I've had patients with heart attacks, same thing. So since PCR tests are hypersensitive, you know, 40 versus 33 cycles, with a reason that the amount of deaths are inflated, as well as the number of infected, maybe by a factor of 10. So it looks like we then have to divide these numbers quite greatly. And Dr. Becky is talking about T-cell immunity. You know, why are we discounting our ability to fight infectious agents? You know, why are we now only relying on scientific measure versus our God-given right? So here's the study, or here's a work funded by NIH, National Institute of Allergy and Infectious Disease, published August 4th, 2020, found that of the SARS-CoV-2 and common cold coronavirus fragments that were most similar, they saw 57 cross-reactivity by memory T cells. So it means an individual that has a common cold that created a T cell cross-immunity by 57%. So it means that even though we may not be exposed to the specific virus we're dealing with right now, the SARS-CoV-2, but because of what we've dealt with in the past, our T cells have a memory to address and to support the immune system in that area. So supporting the immune system becomes crucial. Again, medical motto, first do no harm, and are we doing more harm by overreacting? Next, please. Next, please. Oh, I'm sorry. Can you back up one? For being impatient. Okay, so the mask, you know, how effective is it? So far, you're talking about studies. No study exists that shows a benefit from a broad policy to wear masks in public. It doesn't exist. To date, its benefit to prevent spread has not scientifically been validated. It is based on assumptions. It's exactly the same as we once assumed the Earth was flat. It looks obvious. I can't see beyond the horizon over there, so it's got to stop. And it's the same thing. We got a mask. So, well, that would seem obvious when I'm coughing. Obviously it stops something, right? And yes, it does stop something. It stops about 90% of these, little droplets. But what are these stopping? Well, they're stopping the big droplets, the things that pretty much just fall on the ground. I mean, when we're dealing with Ebola, right now we have a 6 feet distancing. Ebola, we had a 3 feet distancing. So, what is Ebola less dangerous than this, or I'm a little confused where we got the 6, 3. So the viruses, they're tiny. So the ones that hang out in the air for a longer period of time, these are the tiny components. And the mass, I mean, basic physics and biology, the mask can't stop that. It will still go through the mask. So, I'll go back to that a little bit later. Here's kind of an interesting thing. There was a 50% decrease in post-operative infections reported after omitting surgical masks. So getting rid of the surgical mask, then 50% decrease in post-operative infections. So now we're dealing with a group, a person being operated on. I mean, I would consider that as an immunocompromised individual, but we're dealing with a decrease. And this was after, 3,088 patients, so it's not a small study. Next, please. So here, we're looking at transmission. Oh, thank you. Appreciate that. Transmission done through exhaled breath. It hasn't actually been proven. It hasn't. So if that hasn't been proven, then obviously all other findings are irrelevant. So the only way to prove the presence of a virus in an air sample is to actually see the virus under an electron microscope. All we've seen are little genetic fragments. We haven't actually seen the virus. So the WHO says that the evidence of viral RNA in an aerosol or droplet is not indicative of viable virus that could be transmissible. So there's little evidence to support the effectiveness of face masks to reduce the risk of infection. So that's Cambridge University Press. Fairly prestigious location. Next, please. So now we're looking at the potential harm. So if we have established that there's nothing scientifically proven that this benefits us, so could there be a harm? Well, so as we're having the mask, obviously, if you use the loaded mask, it can actually become a source of enhanced transmission for the wearer and people around you. So here you got a mask, and you are breathing out these droplets that is environment. Things replicate in human warm environments, and then you're adjusting it, and then you're touching a handle, or then you're picking up the fruit, and then somebody else comes after, touches that handle, picks up that fruit. So now you're creating a greater risk of spread using the mask. So the mask becomes collectors and retainers of pathogens that the mask wearer would otherwise avoid when breathing without a mask. So we're adding a layer of contamination using the mask. So droplets captured by mask atomize or aerosols into breathable components. So the question is, can virus escape an evaporating droplet stuck to mask fiber? So let's say we are capturing these little bigger droplets with virus in them, and these are the ones that are heavier that would have just fallen to the ground anyway. And the ones that are aerosol, the tiny ones, I mean, obviously the mask, the force within the mask is not big enough to stop them, so they're going to still be out in the air. So there's no change there. So, but now we have these things that would fall into the ground, they're now in the mask, and now every time we're breathing, now we have a chance to then aerosol those particles out and to make them hang in the air. So now we're increasing the concentration of those particles in the air. So, talked about dangers of bacterial and fungal growth on used and loaded masks. What happens in the mask, when you're creating that environment. Again, touching, what happens. Then we have the long-term health effects. People are complaining about headache, anxiety, rising from rebreathing air with 10 times increased carbon dioxide levels. So normal air has 0.4% of carbon dioxide. Exhaled air has 4%. So, in one of my interviews that I did, I run a radio show where I get to interview smart people. So this was a researcher in brain, brain psychology, and she mentioned that just a slight, minute increase of carbon dioxide in the air that you're breathing in, hardly detectable, increases anxiety and anger tremendously. Just a minuscule change. And here we have a 10-time increase change. So what kind of impact does that have on your body? So, and then we're also looking at the negative social consequences to mass society, children's neural development, empathy, feeling disconnected, all these different things that take place when you're walking around in society with everyone walking around with a mask. So, and this is really important for me with children. I have 4 children. So face recognition is an important index in the formation of social cognition and neurodevelopment in humans. So if we take away face recognition, the impact it has on our children in their neural development. We're trained to read faces and then respond so that we can interact with our group around us. And if we take away that portion of the training, the part of the brain that does that becomes underdeveloped. And what are the long-term consequences of that in our children? Negative psychological consequences, wearing masks, fear-based behavior modification, environmental consequences. Now we've got a bunch of masks we got to get rid of, or we're going to put them. And also this, a friend of a friend runs a lab in Germany, and they kind of check these wonderful masks coming from China, and finding then that they contain a lot of garbage in them, heavy metal particles, some even glass fibers in them, you got Teflon, formaldehyde. I mean, so we're breathing this in. So here you got weak respiratory tract, and you're going to be breathing that in. What impact is that going to have? You're concerned about a cytokine storm in your lungs, so this will definitely help. Next, please. So these are therapies to explore. So there are other things out there. You got high-dose intravenous vitamin C, this article, inactivation of SARS-CoV-2 by ozone treatment, adjunct low-level laser therapy. And so that's, we do intravenous laser therapy that treats the blood as it's passing by. Photodynamic therapy is the same thing. You use a laser using light, ultraviolet, blue. You can combine that then with like methylene blue, inhibits replication. You have riboflavin, vitamin D2. Combine that with ultraviolet light. It's very, seems to be very effective. Next, please. And so, why the vaccine? So, we got a 3% infection rate, potential inflated by a factor of 10. 2% death rate, potential inflated due to financial incentives. So if you add that, your total death rate should be 3% times 2%, which equals 0.06%, and that's still a highly inflated number. So this is the risk we're dealing with, and we're wanting to create these legislative actions and this financial impact in the United States based upon that number. Now, when we know that T-cell immunity we already protect, and we also, so now we're dealing with the largest, fastest scale up in vaccine manufacturing history. Concerning. And so with this, what they're doing is that they're monitoring the individual for several weeks. Well, that's wonderful. Several weeks. Could something happen maybe in 2 years? I don't know. I would think that it would take a little bit longer time to make sure that this is safe and effective. So what's driving this forward is still that 0.06% that may be in play. So, and one concern of all the corona studies of vaccines in the past, they failed because of this component here, pathogenic priming, which means that you get the vaccine, so now you have the virus, and then when you're exposed to the virus, now you're primed to have a stronger immune system reaction to that virus, which can then cause severe critical illness and even death is what they call it. So if one drug is safe, are all, so if one vaccine is safe, are all vaccines safe? No, we can't just make that assumption. So thank you so much. I really appreciate you guys taking the time listening to me today.
Thank you, sir.
So Oregon has 2.5 million more people than Idaho.
Okay.
Washington has 6 million more people than Idaho. Oregon's case rate daily is less than Idaho's, and Washington's the same as Idaho. They both have mask mandates. Why?
Why they have
Why
less-
they are less than us
Okay.
per population.
Yeah, so there's so many factors they gotta look at. You could also look at when England introduced mask mandates, and you look at the curve then on case rates, and it just skyrocketed at that time. So,
Well, it's skyrocketing because the infection started before they started the mask mandate. Because it's a 10-day, 2-week event before you'll see an effect.
see the increase, yeah, exactly.
All right,
Yeah,
so that kind of proves against what you just said.
Actually, no, that's not true, I'm sorry. I've got all kinds of.
I disagree.
Yeah.
But you actually don't have the authority to mandate it anyway, so it's the whole point.
I think we do, actually.
No, you actually don't.
Can I say something? Yes, go ahead, Kelly, please. You know, my daughter works for a doctor, Dr. Snow in Caldwell. Anyway, and she got staph infection from wearing a mask. And that's just a fact. That's a fact. The Dr. Snow will let you know that. The other thing is I used to do soil fumigation. If I was to wear an N95 mask, I would be sick. I would die. I had to wear a certain mask. Full face, special mask. So the chemicals that were in the tellome were so small that you couldn't see them. You couldn't, but they were so small that even an N95 mask or any of that, I would have died out in the field. When you do tellome, you have to have 2 people in the field, the operator and someone to watch, in case your mask fails, because you will die. So we're saying that, you know, that's where I get off on the mask thing, because just like you said, those particles are so small, they're going out there, they're airborne. That's the same thing. If the right mask is the only way you're going to stop the flow of it. And my daughter wore a surgical mask and got a staph infection from it. And that's a fact. You can't deny that. So I have a lot of concerns of what we're trying to do.
And the basic physics, when you're coughing, I mean, unless it's 100% sealed, it's gonna go somewhere. You know, so now you're spreading in this direction, you're spreading in this direction. So now you're getting things up in the nasal cavities, which then have a higher introduction to brain, to neural. And then obviously, again, touching things. So I'm not sure, I mean, obviously,
So, but going back to what you said, that bacteria, where's it coming from? It's coming from your mouth and your nose.
Exactly.
That's already there.
Well,
So breathing that,
here, and then bringing that up here,
I'm here to tell you that your mouth and your nose is a hell of a lot dirtier than your mask.
absolutely. And
So
why
how can you then say that this is doing it?
So why
Because they're already there.
Yeah.
The bacteria are already in your mouth, already in your nose.
So, but why are you concentrating that and and then you're breathing that deeper in?
It's already going through my nose, already going through my mouth.
Then wear it.
It's already there.
You were your mouth created a reason to exhale.
All right, we still have 2 presenters.
Okay, let's go on. We're behind.
So, we need to get on, we've kept them waiting an hour. And like I said, this is informational for all of us to hear and listen and make our own choices. So now we have Dr. Michael Schulte and Dr. Sky Blue.
Hi, Dr. Sky Blue here. I'll go ahead and start and watch my time and stick with my 15 minutes. You know, I really thank you for the opportunity to speak with you here. And, you know, I find myself with an increasing sense of desperation and helplessness in our crisis. You know, to use that tired but vivid cliche, is like watching a passenger train derail. Not many have seen that, but it's hard to imagine, you know, the tipping point where the process starts in a slow, forceful, and inevitable catastrophe, helpless to stop the railroad cars involved, only hoping that the momentum will let up before more cars, more people are involved, watching and waiting before you can help. You know, and might come back to this in a minute, but first let me tell you why I offer my voice to your deliberations. You know, my grandmother moved to Idaho in 1948. My grandfather worked for the railroad. They moved from Huntington to be close to the growing community around Caldwell. You know, it was the Black Canyon Canal at that time that was drawing people. You know, my father attended the College of Idaho when it was first named that. I still have uncles and family living in Canyon County, Gem County, in your district. I moved here in 1997 to be close to family. Completed medical school at University of Iowa in the midst of another disease, HIV/AIDS. You know, I trained in internal medicine in Arizona. I was an infectious disease fellow at University of Utah. I studied viral infections, epidemiology, and during my professional career also have traveled Nepal, India, China, Mexico, treating and studying infections. I was faculty member in University of Utah in both infectious disease and geriatrics before moving up here to Idaho. Here, I've worked at both St. Al's, St. Luke's. I've been a medical director for the first HRSA grantee HIV clinic since 1998 in our state. I'm in independent private practice, a small business owner with 8 other clinicians. You know, I work at both St. Luke's and St. Al's hospitals, as well as 2 clinics here in both Canyon County and in Ada County. I'm a full-time clinician. My patients are my foremost loyalty. You know, I tell you this because, you know, I learned as a youth soccer coach that people don't care what you know until they know that you care. And that's why I'm here today. You know, and I hear the passion in the voices of everybody speaking today. You know, and I'm here, I hope, for the same reason they are, is I care about my family, my neighbors, and our state. You know, I'm sure Dr. Wool will recognize that Matthew 22:39, love your neighbors as yourself. That's who I'm here for. It's our neighbors, our state. That's why I'm here. I'm seeing this pandemic, it's now worse than it's ever been. I think we're at a tipping point. You know, the momentum of this spreading infection is like that train. We're moving fast. And right now, our behavior is the only thing we have right now to change this trajectory. You know, we talk about government and all this other agenda. It's really our neighbors that we're talking about here. And when we talk about, you know, I love the passion and all the questions. I even heard somebody saying, what can we do to protect our family? What can we do to protect our neighbors? So let's talk about that. You know, I agree with Dr. Wool. Pillar number 1, stop the spread. That's, you know, I enjoyed her talk about, you know, pillar number 2, how to treat, you know, those who are outside the hospitals. I'm in the hospital treating those in pillar number 3. And I'd like to come back a little bit to pillar number 4. So let's talk about that pillar number 1, stop the spread. And listening to, you know, the both the speakers in the audience there, as well as our other guest speakers, I agree with lots of that. You know, we really want to stop this spread. Even before we want to treat somebody who is infected and at home, let's stop the spread. So what do we have to do that? we talked about, is there anything scientific about 3 feet or 6 feet? Of course there's not. We got to have, some guidelines in there. It's just like how wide do we make the lanes on our roads? We don't know that. How long do you keep a yellow light going before it turns red? We take our best guess on that. This disease is spread person to person. So how can we prevent that? Well, certainly we can all stay at home. We've talked about how we hate to do that. But next up is, can we bubble? Can we bubble with our family? Can we bubble with a group that is also taking the same precautions we have? Can we stay out of indoor air where others are congregating? If we have to do those things, what can we do to prevent transmission in those situations? We can keep our distance. Is 3 feet better than nothing? Yes. Is 6 feet better than that? Probably. Can this, when somebody is coughing, spread droplets 12 feet or more? Yeah, probably. Is singing in an indoor space, can that transmit disease? Yes, it has. So what can we do in that when we can't distance, when we have to be in an enclosed space? We can wear a mask. We talked about, a lot of things here, and I came prepared and with data as well. Looking through the studies that we're talking about or out there. I was looking at it, and since March, I've been looking through preprints, probably 100 or more a week. Reading the data, looking at those studies, what they're trying to do. But as I was looking for this, and we can criticize the CDC and what's been happening with them through this pandemic and what they're trying to do, but there's good people there, and they just adjusted their website with a new look at masks, and they give you those studies. They're fully referenced with links that you can click on. The data is there, and so I hearing what we're saying here, and I'm surely not hearing that we're recommending that surgeons not wear masks when they're going to do your hip replacement or your knee replacement. That, we even had a speaker from the audience saying, why do we wear masks? Doctors wear masks to prevent the spread of germs. So let me save on that, because the data is out there. And I don't want to turn this into, looking at the methods and the authors and all of that, but it's out there. And any board member who wants to sit down and go over those data, I'm available, call me. If we say, what can we do? And we keep throwing out this dichotomy about the economy or wearing masks. If you look at the people who are responsible and want to hear about the economy, Goldman Sachs, they looked at this and they saw that a mask mandate in states increased mask wearing by only 25%. There's people who won't wear it. But when they did that, they reduced the rate of new infections by almost 2%. And when they looked at this in the summer, they said that would be enough to be equal to a savings of 5% of our GDP. So if you want to keep our businesses open, if you want to save our economy, wear masks when you're out in public. Nobody is saying you need to wear a mask when you're at home with your kids that they can't see your face. If you're with a bubble and you're outside, nobody's saying to wear these masks. All the risks of masks that you're talking about, God bless our healthcare workers who are wearing these day in and day out for hours and hours in a day for your health. When you're in an office, I don't wear a mask. There's nobody around. When I'm outside in my field, I don't wear a mask. When I'm working with my horses, I don't wear a mask. So the idea that wearing a mask is bad for our health, it's like saying hand washing for our food service is bad for our health. Those are things that, use your common sense and ask why somebody's talking about that when we spent so much time talking about pillar number 2, which is treating those who are infected. So, beyond that, where are we now? And, you look at those who are trying to find where this is spread, and you try to say, where could you have picked this up? We're in a state right now, we're in the state of Idaho, but the way we are at is nobody knows. We can't say this came from this person. We are in a level of community spread, which, every interaction carries a risk. We talked about testing, and let me bring this back to this. We talked about how the PCR test is very sensitive. Yes, it is. It picks up the genetic fingerprint of this virus and this virus alone. And so, as you say, it's like picking up a hair in a room where somebody has left the room. You're exactly right. That's why we use it. Because if you would have checked for that hair when that person was in the room, you would have found a head full of hair. We don't test people at the best time in their course of an illness. If we did, you can use almost every test and it would be positive at those levels that you described, the low CT thresholds that show infectious virus in the millions or billions. That's where you are at the peak of this infection. So when we're not treating or testing people at that time, we're using a sensitive test that can say, yes, this was an illness you had 5 days ago, 7 days ago, or you're in the process of becoming sick with, and you're going to become symptomatic in a day or two. This virus is unique, but it's also like some of these other viruses you mentioned. We can talk about the T-cell immunity. That was a fascinating trial that looked at stimulating T cells taken out of a body in a test tube. It does not talk about protection. It is a complicated trial that even I have a hard time understanding and have to talk to my immunologist about how we determine what is a memory T cell and is a T cell that is learning a new infection to give those results. But it's fascinating. Is there something to some of these seasonal coronaviruses? We don't know all the details from that, but we're seeing people getting sick and we're seeing people die. We talked about, calling a death to COVID. The way we look at this, and we have for every year, and nobody has, cried fraud in that, is looking at excess deaths. When we look at the average of deaths that we have in the United States, and we're pretty darn good at it because we have nobody in the US, unlike India and a lot of other countries, people are born, we have a birth certificate. When they die, we have a death certificate. We've been studying this. So when we look at excess deaths during January to October of this last year, there's been almost 300,000 excess deaths. That's higher than the number of cases or deaths that are even reported to be from COVID. So those excess deaths are from what? We're smoking more, we're driving faster. Yeah, maybe, but I don't see that. So use your common sense and look at these issues. So let me finish up in talking about vaccines and herd immunity. Are vaccines safe? We don't know. We haven't seen those data on those yet. We talked about every medication has a potential risk. Absolutely it does. I love Dr. Wool's discussion about, what we can do to be healthy. She talked about eliminate sugar. Sugar isn't illegal. You could stop smoking. Smoking isn't illegal, but both of those things can improve your health. The Wall Street Journal says that we lose $90 billion in our economy every year to diabetes. By all means, fix that. So are vaccines safe? We don't know. You have to balance that with the disease. What about the vaccines we're coming up for COVID? We've had 2 press releases. We've had some animal data looking at these. Let me just address a couple of them so you know what I'm looking for as these come out. First, the Pfizer vaccine is an mRNA vaccine. The Moderna is similar. What they do is take the genetic fingerprint of the template for making the spike protein, which is how this virus attaches to human cells. And what they do is they get that template, they put it on something called mRNA, messenger RNA, which our cells use as a template to build proteins. So instead of giving an awful lot of protein in that shot, they can give a much smaller amount of the template, which is encapsulated in nanoparticles that are taken up by cells, and they are not incorporated into our genome. They only use the cell material to build that protein. And especially as we talk about cell-mediated immunity, it's a great strategy because that protein is then on the surface of that cell, which is recognized by our T cell immunity. T cells are important to stimulate B cells, which make antibodies. IgM, as Dr. Will pointed out, is an antibody that can be made by B cells without T cell help. IgM is our least active antibody. It has the least affinity for the virus, but it is in it's in a molecule of 5 active ingredients, so it actually is a great first one to get out there. Then the B cell takes over and makes IgG, which is the long-term immunity. But that immunity stays in our bloodstream. So when we immunize individuals, and the first studies have shown us that the antibodies produced in the bloodstream are equal to or greater than those of the individuals who donate convalescent plasma who've recovered from an infection. So that drove us into the phase 3 trials where they vaccinated a large number of people, 30 to 40,000 persons in each of those studies respectively, and they looked at who got sick. So all we know now is the reporting of clinical illness in those 2 groups. And they found that 90% of those infections with clinical illness occurred in those who were not vaccinated with the real vaccine. Do we know much about safety? We almost have about 2 months of patient data in that. So it's pretty short to be telling a lot about infections, about the safety. And we haven't looked at the data yet. It hasn't been released to be studied by any outside individuals other than the data safety monitoring boards, which are separate from the companies themselves. If we get these vaccines, they may be available by January. We don't know how much will be available and how we're going to get those. Right now, the Pfizer vaccine has to be on dry ice until the day of vaccination. The Moderna is more stable and can stay at regular refrigerator temperatures for a lot longer. So as we get it available to those who want it, we have to be looking at this. We hope that it'll protect individuals from having severe disease and from dying from this. So people who don't want to die are the people that will want to get that vaccine. We're seeing that it might prevent mild disease. We can only hope that it might prevent transmission. We don't know that. We don't know if it'll contribute to herd immunity. Influenza has very poor herd immunity because even if you've had it and recovered it, you can still be infected in your nose enough to be transmit that. And we've seen that in reinfections, individuals who've recovered from COVID and have been found to be reinfected. So we don't know whether this will prevent transmission. And so whether we do that to protect our neighbors or not, that's going to be up to you. We hope it'll be available for those frontline healthcare workers, our essential workers, and those who may be at higher risk, has been so elegantly pointed out by our other speakers. So, I concentrated on your first pillar and the last, hopefully give you a little bit more information to ponder with that. When you have a lot of this information, ask, is somebody trying to manipulate me? What are you trying to get me to do? And I just kind of come back to it with another quote. Every death diminishes me. I see this in the hospital. That's, for who the bell tolls, it tolls for thee. That, and what I started with, it's, love your neighbor as yourself. That's who we're doing this for. And those are the two things that if I'm trying to manipulate or help push in, those are the two areas that I would have you take away from this. Thank you.
Okay. Thank you, sir. Okay, still have Dr. Michaela Schulte.
Yes, thank you. Can you hear me all right?
Yes, ma'am.
Yes.
All right, thank you. Thank you for the opportunity to address this board and share some of my thoughts and concerns as a frontline provider caring for hospitalized patients. My hope is that this also will provide you with some additional information that you can take into consideration as you decide how to best lead those who are looking to you through this crisis. A little bit about me. My name is Michaela Schulte. I'm a board-certified physician in internal medicine and also infectious disease. I graduated medical school in 2000 and moved to Nampa over 11 years ago. Since then, I've been living and working in Kenyon County as a hospital-based physician. Initially at Mercy Medical Center, for those who still remember that. Unfortunately, the building is now gone, then at West Valley, and most recently at St. Luke's in Nampa, where I also serve as the Vice President of Medical Affairs with responsibilities for Nampa and Fruitland. As part of my administrative role, I've had the opportunity to help shape our COVID-specific clinical and organizational response since early March. In my clinical work, I admit and care for adult patients who require hospitalization for any kind of medical condition and complexity. My scope of practice in the hospital ranges from the regular medical floor to the more advanced telemetry unit, as well as the intensive care unit. We've learned a lot about the virus and the disease it causes since it first emerged and hit our shores. And even though we've made some progress in how we care for those who develop severe disease, we're still lacking treatment options that effectively stop the progression of the disease, especially in the most vulnerable. You've heard comments by Dr. Blue and on the seriousness of the situation we are finding ourselves in today. I can tell you that today, this morning, I just looked it up, in the Nampa Hospital, about 1/3 of the patients, actually a little bit more than 1/3, are COVID positive. Our telemetry unit, providing the level of care required to most of these patients, is at actual physical capacity. We have been completely filling all available and staffed beds most days in the past couple of weeks with really no end in sight. Currently across St. Luke's, we have 130 COVID positive patients that are hospitalized. This is about 30% higher than what we have seen at the worst point following the July 4th holiday. Without some actions to slow the spread of the disease in our communities, we expect the numbers to increase substantially in the weeks following Thanksgiving. Our capacity of care is seriously eroding, and we're getting fairly close to a breaking point, or as Dr. Blue said, the derailing of the train, where we will no longer be able to provide the level of care we're used to for really anyone presenting to the hospital, regardless of their diagnosis. To help address these capacity and staffing issues, St. Luke's will no longer schedule any procedures that would require an overnight stay that can safely be delayed by 90 days for at least the next 6 weeks. In Nampa and several other facilities, we have already canceled any of those procedures that were scheduled for that category in this week. And we anticipate to schedule more in the coming weeks, to cancel more, maybe correct, sorry. In addition, we need to, the need for COVID care in the hospitals, we need to maintain the capacity of care for heart attacks, strokes, car accidents, other emergencies, just as Dr. Wool and her colleague have said. Here's some of the points I would like you to consider because I found them to lead to some confusion. As Dr. Wool actually also stated, our hospitals are not staffed to run at 100% of their physical capacity, meaning every room and every bed is filled for prolonged periods of time. However, not even hotels or other service industries where workflows include specific checkout and agreed upon arrival times function that way. And unlike those industries, in matters of health, prolonged wait times and limited access cause harm. A prolonged wait time in the ED can easily mean the difference between making a quick and uneventful recovery versus serious prolonged hospitalization and even death. Additional staff who is meeting the necessary qualifications are no longer readily available. We are no longer able to fill any of our traveling nurses positions and to add to those that we had already brought in. And to be clear, St. Luke's did not furlough or lay off any staff during any time of the crisis. Nurses qualified to care for ICU patients in particular are incredibly high demand and incredibly short supply across the nation. And so are many of our specialized therapists, for example, our respiratory therapists. Not just anyone can step into those jobs, especially at the level of complexity that is required. In addition, hospital staff lives in the communities we serve and sadly are also getting sick as well, limiting their availability to work and further eroding our capacity of care. Also, if we can't discharge patients, then we run out of room to admit those who are acutely ill. Our rehab facilities, our nursing homes have been hit especially hard. Many facilities had to deal with serious outbreaks and many lives have been lost in those populations. In addition, the number of residents and patients who can be safely cared for in a facility presently had to be limited in many instances. And staffing shortages there are also leading to very few beds becoming available for us to discharge to, creating significant bottlenecks for us in the hospital. This is even more pronounced for those patients who require some rehabilitation after recovering from COVID. Only very few facilities will accept a patient before they are beyond their 20th day of illness, so they reduce the risk for spread. The same is also true for patients requiring inpatient behavioral health treatment. Access is limited due to the same constraints, forcing patients in crisis to wait in the emergency room for long hours, which in turn further limits the access to those who are seeking care in the emergency room. This impact also trickles down and is felt particularly strong in our rural hospitals, who rely on transferring sicker patients to a higher level of care, which is us, irrespective of their COVID status. However, those patients can't be moved until a bed becomes available. This leads to long wait times in the ED with impact on safety and the quality of care that we can't even measure. In addition to these considerations, I wanted to clarify a couple of other points that, in particular, in my day-to-day conversations with my neighbors and other people in the community, I seem to find people confused about. First of all, it's not simply the old and sick who develop severe illness or require hospitalization or, God forbid, are dying from COVID. We have had a mixture of almost all ages admitted to the hospital, including the ICU, and sadly with any kind of outcome. First of all, old, we all know that is a relative term. As I, age, I realize that every birthday, ever more so. It's not only in the context of medicine the case. While there is certainly a strong correlation for risk of severe illness and death with age and pre-existing conditions, we've heard that already here today. We have seen many patients in their 30s to 50s with no or fairly minor and really well-controlled medical conditions who also develop the most severe illness, requiring prolonged hospitalization, or who have even died. And just on a side note, don't want to get off on a tangent, why do we even allow the implication to be made that somehow the number of years somebody has lived or the health conditions that they have been faced with are making his or her life less valuable? COVID also causes seriously potentially life-threatening complications independent of age, pre-existing conditions, and severity of illness. Dr. Wool mentioned that. We're seeing significant numbers of previously healthy patients who are now presenting with pulmonary embolisms. Those are blood clots that go to your lungs, heart attacks, strokes, either during or after a really relatively mild course of COVID, something that we have never seen before to this degree. Another point I would like to make is that the outcome of COVID is not binary. You either fully recover or you die. This is, when you look at the statistics, what one might believe. What does not get much talked about, and I believe that is because it is difficult to measure, is the large number of patients who experience persistent negative effects on their health for weeks and months after they recover from the acute infection. People report ongoing shortness of breath with limited physical activity, a brain fog, headaches, continued impairment of taste and smell, amongst other debilitating symptoms. Many are prevented to return to their previous level of activity or resume full-time work for many weeks. For those who require hospitalization, about 1/3 experiences prolonged symptoms and a long road to recovery. In addition, we don't yet even know the potential long-term effects the illness may cause. There's the concern about the inflammation the virus causes, that it may lead to scarring and some risks for longer-term chronic heart disease, lung disease, or other neurological processes. Last but not least, and this is really the most important thing to my heart, we are doing our best to help our neighbors and our community through this crisis in a safe manner. However, our resources and our people are strained and are becoming more so by the week. Not only is the sheer number of patients and the complexity of care that is required taking a physical and mental toll on our nurses, physicians, and other clinical staff, they're also becoming increasingly emotionally exhausted and demoralized. We pride ourselves in providing compassionate care to anyone in need, regardless of their walk of life. However, it is becoming difficult to insulate ourselves from social media and other voices who suddenly, without real proof, doubt not only the reality of what we're experiencing, but also our intentions and integrity as professionals. Hardly anything is more draining than to hear someone tell you, it's just the flu, or even completely doubt that we are caring for any COVID-related patients after you have just worked for 13 hours, forgoing food and drink for long periods of times, for the need of wearing personal protective equipment. And never mind the fact that even in a relatively mild flu year like 2017, I believe 255 Idahoans died from influenza. Our death toll for COVID today is more than 3 times as high and still climbing. Let me remind those that doubt us that we are still the same people with the same professionalism who have been caring for this community for decades. And by the grace of God, we will still be here to care for patients long after this pandemic abates. For those who grapple with whether or not they can trust the information we provide, I just provided, I'm asking you to recognize us as the professionals that we are, to listen to our experiences and perspectives, and to treat us with the same respect we demonstrate to those who seek our care. My wish for our community for this holiday season is that we care for each other and protect the most vulnerable amongst us. Wearing a face covering, avoiding gatherings, especially indoors, washing our hands are small acts of kindness that can save lives and protect the health of our loved ones and our neighbors. I know that you who serve on this board want to protect the health of the community you serve in this public health district. I ask you that you take actions that will make a difference today. Thank you for your time.
Thank you very much. Okay, any questions, Doctor?
Can I make just a 30-second statement?
Okay.
One of the things we lose sight of is the reason for hospitals, it's not for the physician. It's for the nursing care, it's for the RT, the respiratory therapy, it's for physical therapy, it's for pharmacy. You know, if a patient is sick enough or well enough that they can have their surgery or their heart attack or whatever, and they can go see Dr. Blue, Dr. Schulte every day, that's fine. The reason they're in the hospital is because they can't take care of themselves. They have to have nursing care, they have to have pharmacy or physical therapy, respiratory therapy.
Okay.
And I guess I worry that, you know, the nursing, et cetera, the numbers are dropping, the burnout rate is very high.
Okay, thank you, sir. Appreciate that. Okay, let's see, my watch says it's time to go home according to to our agenda. But we highly appreciate those who have spoken to us today, given us their thoughts, their expert opinions and you know, for the last, 8 or 9 months now. With that, we need to get on to the business that we have to conduct here. So, was there any other questions for Dr. Schulte? If not, we will continue with our local business. Yes?
Mr. Chair, I'd just like to close up this portion just by saying thank you to all of the folks who have spoken. And I think it's really important for people to see, you know, people have commented on the passion that we've seen in a lot of people. But I just want to say thank you to Michaela, for Dr. Schulte, for showing your heart, and for showing the things that you're dealing with that people are discounting and saying poo-poo to. That's painful, that's harmful. And so thank you for what you're doing in the hospitals and for all of your staff and all those nurses. Just give them a big hug if you can.
All right, thank you, sir. Appreciate that. And thank you. All right, on to our introduction of new employees. And I don't know who's doing that. Staff, it says.
Yeah, I believe, because where we are on the agenda, I don't know how many people we have around, but I think Jamie has some new staff. I don't know if she has them present to.
Okay. Would it be appropriate then maybe to take a 10-minute break and allow them to get things put together, because we're so far behind in the...
Yeah, it looks like Jamie is nodding on the camera,
Yes.
what I can tell.
Mr.
Yeah,
Chair,
I think
we could assemble. If you take our break, we can.
Okay.
Assemble.
We will then take a 10-minute break.
Okay.
And come back. Okay, thank you. Oh, my goodness.
I feel like you and I never get the break. Everybody else can kind of sneak out.
I know. All right, come on, let the old guy go.
All right, at this time, we will break for a few minutes and we will resume the live stream then. Thank you.
My knees are locked up from sitting too long.
Too long to sit.
Oh, boy.
I remember a state gathering we had about 3 years ago, I think, where we had this nurse practitioner that came in who was like one of the leading national, quality leaders. Gave us a really good talk on health. Basically, her theme was that sitting has become the new smoking. It's just as bad for you as smoking. You just sit all day long.
If you sit all, I agree.
You gotta get up every 40 minutes and move around.
Well, have you seen those, I've known a couple of executives that have gotten those treadmill rescue, and they walk up the aisle.
I have a stand-up desk, you raise a load. Yeah, but I don't know that I could walk.
Well, I think it'd be,
I just don't know that I could do that.
yeah. So when you were in high school, did you ever think hiking was gonna be such an important class?
You know, I don't, no, I never thought. I'm trying to, I don't know if I
I think. Ashley, can you hear us?
Yes, I can hear you now.
Thank you.
Okay. Oh, yeah, sure. We are now back to the introduction of new employees.
Okay.
Go ahead, I'll give time to you.
Hi, everybody. Jamie Anderson, Environmental Community Health, and we have quite a few new employees, and actually this isn't everybody. I'll be bringing more next month, but I'd like to let them introduce themselves to you. So I'll start with Charlene.
Hi everyone, my name is Charlene Terrio, and I'm the new Community Health Program Manager, and I will get to work with these two, and I will let them introduce themselves.
Haley Tilton, I'm a health educator with this background. And my name is Emily Strubar, I'm a health education specialist. I split my time between the Behavioral Health Board and then the Suicide Prevention Program.
Okay, very good.
I'm Samantha Kenny, and I am the new Project Manager, and I will be managing the Crisis Center grant and helping with strategic planning and any kind of Thank you.
Okay, thank you. Now,
Oh.
speak up, please. Some of us that are old, had a lot of birthdays, can't hear good.
I know, really. Hello, my name is Susan Tuttle. I work in the environmental health section as an office specialist.
Hi everybody, my name is Claudia Barrios. I'm actually doing the clinical records, so I work with the epidemiologist department.
Very good. Welcome.
We range from, Sam's been here day 2, this is day 2.
Okay.
Week 2.
We can classify them all as newbies.
Yeah.
Well, welcome. Thank you. So welcome.
Yes, very much.
Thank you for appreciate it.
Thank you very much.
Thank you for what you do, or will do.
Bye-bye.
Okay. Approval of our October 2020 minutes.
Mr. Chair, I'll move we approve the minute.
Okay. I have a motion and a second here. And all in favor, say aye.
Aye. And I read them, so.
And so did I, actually. So thank you. Okay, that,
We got a break.
now we're gonna skip our break that we just had. October 2020 expenditure and revenue report from Troy. And if
Good morning,
he's still in
everyone.
Hawaii.
So I wanted to real quickly, while we had a chance, I do have a new employee as well, so I wanted to introduce her. Her name is Stephanie Soto. So I'll introduce her and step out of the way.
Hello, good morning. Like Troy said, my name is Stephanie Soto, and I am the new Office Specialist 2 in General Support.
Very good.
Well, welcome.
And keep Troy in line.
Yes, yes. Somebody has to do it. All right. Okay, well, I'll move on then with the report. Thank you, Stephanie. I'll just move on with the report, and you should have the report in front of you. This won't take very long, but I just want to make sure I give some time for questions or thoughts. So if you look at the report, and I'll take my mask off now that she's gone. If you look at the report, you can see up in the upper right-hand corner that our target percentage where we should be at is at 33%. And you can see also in that upper hand corner, this is where we track our year-to-date cash position. So our current year-to-date cash position is in the positive, and our net change for October is also in the positive. Now, this was a result of, if you remember from last month, we were actually the other direction. So one of the challenges that we faced with our COVID billing is that it's very cyclical. So we kind of ride on this little roller coaster where we have expenditures happen, and then sometimes that reimbursement doesn't come back to us right away. So maybe it takes a month or 2 months. So we might have this dip in our cash position being upside down, and then it kind of rises back up. So if you're looking at, and I'll show you, we'll go over the graphs in just a minute, but primarily the change in that has been based on we had a little bit of a bump in personnel, and that was because we had 3 pay periods in October, but we also had a decrease in operating. So that's why that 64,000 positive net cash position for October is that rate. It's just because we had a little bit of a dip in operating and an increase in revenues coming in from prior billings. In the overall net cash position, you can see that's still a little bit high. A good chunk of that comes from our billing, again, reminding us that we had a good chunk of money coming in from fiscal year 20 that landed in fiscal year 21. So a good chunk of that net cash position in the positive for the year has come from fiscal year 20. But that is because it lands in fiscal year 21, we just have to continue to report it. If you look down then on the table, you can see that our percentages for fees collection is approximately at 35%, so we're kind of on par there. Our contracts revenue is much higher than normal, and that is based on our COVID billings and our COVID contracts and subgrants billings back to DHW, the Department of Health and Welfare. And then you can see our interest is currently at 17%, and our other committed funds are at 4%. So that's the revenue, where our revenues stand. And then on the lower expenditure portion, you can see that we're at 43% in personnel. So that does represent an increase. We're a little further along in personnel than we should be in a normal year. And the reason for that is obviously because of, and you've just met a whole bunch of new staff. Our staffing has increased quite a bit, and that 10% is probably not too far off from reality in our increase in staff levels. But you can see right below that operating is down at 24%. Again, from last month, we had a pretty high operating cost, and some of this is also related back to the crisis center. So as crisis center billing has been a little bit, I've been working with Steve over at the crisis center to kind of get that a little bit more stable in timing. So if that timing gets a little bit off and we wind up paying two crisis bills in 1 month, it'll be low 1 month and high the next. And so that's also contributing to some of that as well. And then you can see our capital outlay is at 13%. So we do have some plans to get through the capital outlay, just it has not at this point happened. Any questions so far?
Commissioners? Yes, Kelly.
What is designated as one capital outlay? Where are you going to put? What are you going to do with the capital outlay? What are you going to bring in?
So that's a great question, Commissioner. So what we do, so there's essentially two definitions for capital outlay. There's essentially a federal position and then the state's position. So what that distinction is, without getting too far into the weeds, is any item specifically that has a life longer than a year, has an individual cost greater than $2,000, and is something that it could be depreciated, then that is typically what we're calling capital outlay. Now, if it's $5,000 an item, then that again goes into our statewide financials, and it does have to be depreciated. So typically anything that's $2,000 is considered capital outlay. If it's equipment, anything that has, like I said, a durable life longer than a year. Some of those exceptions are computing equipment. So the statewide policy allows for an exception to like computers, even though they have a lifespan of greater than a year. They're typically under that threshold, so there's an exception there. There's also an exception for cell phones. So we typically will operationalize those costs, and those will get written off in the current year. The prime distinction in capital outlay is the dollar amount threshold and its lifespan. And again, if it's greater than $5,000 per item, then it is included in our statewide financials and is depreciated.
Okay, thank you.
Yes, always.
Very good. I think that was the only question.
Okay. So then going on to the graphs, they're pretty self-explanatory. In the revenues, you can see that we had quite a few higher revenues in October than we did in September. However, the trend is still a downward trend from July. And so we just had a lower amount. And so September was just a little bit of a wonky month, and primarily because of those COVID billings. And just as a side note, so you'll see kind of the opposite effect for November. We did just receive some pretty sizable reimbursements from the Department of Health and Welfare on some billings that we did in the end of September. So that will change in the November report. In the expenditure graph, you can see that, again, personnel is quite a bit higher, and the nature of that rise is because there was 3 pay periods inside of October. So that's why that, and you'll see that again, because there are two segments in the year that have 3 pay periods. But then you can see our operating costs. Our operating costs are actually lower than they've been since July. And so that was just a nature of the primary need for in October was in our payroll timeframe. And then the final graph is our investment yield trends, and you can see that they've stayed really stable to the percentage. Now the thing that's interesting, and I don't know how this interests most people, but it is interesting to me, so I thought I'd bring it up. But you can see in October, you can see that bar graph, actually in the other months, that bar graph gets really close to that distribution line, but on the percentage. But when you look at October, that actually is down from the line. And the reason is that in September, because we had that cash kind of shortfall as we were waiting for stuff to come in, that's when we pulled money from the LGIP account to provide that, and then it goes back into that account as the monies come in. So when that happens, there's less money available to be reimbursed in the interest reimbursement. So that's really the nature of that distance there. Were there any other? So I think that's about it, unless anybody had any questions that I can help with.
Commissioners? I think that's all. Thank you.
All right. Thank you, commissioners.
Thank you very much. Okay. Our COVID-19 situation update with Doug and Jamie.
Morning, Commissioners. This is Doug. Can you hear me okay?
Sir.
So we'll make this brief. I know you all are behind schedule, so I will include some data and some information that you probably need to be aware of, but we'll shorten the presentation probably by a few minutes to help maybe get you back to, well, I don't know if it's possible to get back, but anyway.
So give us whatever you think is important, please.
Okay. All right, will do. So just the first information I would like to present to you would be the numbers over the last 30 days, since the last board meeting, basically. We've obviously seen a huge increase in the numbers over the last few weeks. We've had over 4,400 cases reported in the last 30 days. We've conducted nearly 2,300 investigations. We've also done over 2,000 monitoring calls with those that we've made contact with. And we've also identified 1,370 close contacts from our investigations. So as you can see by those numbers, it's quite large, and it's not slowing down at this point. Just this last weekend, we had over 750 cases reported. As far as the schools go, I wanted to give you some numbers on actual teachers, staff members, and students that have been identified as being positive over the last 30 days. We've had 62 school teachers test positive. We've had over 200 students test positive, and we've also identified 28 transmissions from schools to households. So basically, students or teachers or staff from the schools going home and infecting others in their household. So we had 28 of those that we were able to identify.
Mr. Chair?
Yes, sir.
Doug, just a quick clarification. Is that the schools in the entire district in all 6 counties, or is that just in one area?
Now, this is our total numbers for our district, and it's broken out by county and by school district.
Okay.
As far as our testing goes, I'm sure you're aware that we have been doing testing here at the health district, and I believe that we're one of the few health districts that are actually doing testing at the health district level. We've done, I think we've done 400 and, well, this is hard to tell. I've got a lot of numbers here, but we've done approximately 15 tests per day at the health district using our Binax Now tests, and we've been doing that consistently for the last month or so. We've also provided approximately 11,000 of these tests to our community members, including members of our counties, healthcare facilities, paramedics, long-term care facilities, Department of Correction, and some universities. So these are tests that, rapid tests that actually show positive or negative within 15 minutes. So these tests are very important in getting out to our community or providing the results back as quickly as we can to ensure that we can stop that spread as best we can. We've given approximately...
I have a question for you. Go ahead.
Go ahead.
Doug, what's the percentage, how many is false positives or whatever on the negative or on the testing? How accurate is the testing? That's what I want to say.
So,
for this test.
Right. So the Binax Now test that we actually are doing here at the health district, when we first received those tests, we sent, we took 2 samples. The first one we did ourselves with our Binax Now, and then we did a confirmation sample that we then sent to the state lab to determine if it was in fact positive or negative. So every test that we did for the first couple of weeks, we did double tests. Basically, we did 2 samples, one we sent to the lab, one we did here. And from what I have been told by our testing employees and testing staff in our operations section for the incident response, there was only 1 test that wasn't accurate out of all of the doubles that we did. And they aren't sure the reason for that. Obviously, every other test that we sent to the lab was confirmed as a positive or as a negative when we did those. So we just to clarify as well, out of all of the tests that we're doing here at the health district now, we're running almost 50-50 on people that are positive and negative. So for every test we do, or every 2 tests we do, 1 is positive and 1 is negative, basically. And we only do these on... I'm sorry.
People, right?
Yeah, just symptom. Correct. Anyone showing symptoms, those are the only ones that we do the testing on here.
Hey, Doug.
Yes, sir.
I just wanted to add a little bit of information for the board. The 400 includes the double testing that we were doing. And I just got an update from Lori Sperry that we completed around 250 tests. That's 250 unique individuals. And you're absolutely correct in comparing the rapid test to the what's considered the gold standard, which is an in-laboratory PCR test. We're seeing greater than 95%, it's closer to 99% result concurrence. So when it's a positive on both platforms. We will formalize that and continue to evaluate the Binax Now, which is the rapid test. But I also wanted to add one additional piece of information, and that is the Binax Now is an antigen test. It is not a PCR test. It does not look for genetic material. It looks for a an actual fragment of the virus, a protein, or what we call an antigen. There are 2 other antigen tests that are being used nationally, and primarily in long-term care facility settings. And those tests, especially one of those 2 platforms, has had some issues with false positive rates. We have not seen that to date with the BinaxNOW antigen test, but we're not going to stop there. We're going to do a formal validation study based on our informal kind of operational research we've done so far that looks pretty good. We're now going to formalize that and continue to evaluate our the BinaxNOW test, which is the only antigen test, rapid antigen test that the health department is using.
Okay, thank you.
Thank you, Dr. Roscoe.
You're welcome.
Appreciate that. Any other questions on the testing or the numbers so far before I go on? Okay. I did want to cover a few other items. We have approximately, obviously our website and our social media traffic has seen an increase. Ashley and Katrina have done a really great job in putting relevant material out there for people to view, and they've been doing a great job keeping it updated and providing relevant information for all of our counties and our communities. We've also increased a large amount of Spanish or English and Spanish videos, and I hope some of you have actually seen some of those public service announcements that we've put together and pushed those out. So we've done 12 English, Spanish ones, PSAs, and then we've done 3 Spanish COVID-19 Do Your Part videos. We're also involved with the Hispanic Outreach Task Force. Katrina and Ashley are both involved in that, and they work with many other agencies and community groups to provide the relevant information that they all need within the Hispanic communities as well. Our liaisons have worked with over 50 businesses and organizations to provide support and guidance to them just in the last month. And we've also been working diligently, and I think we have this kind of end in sight finally for the temporary housing for homeless individuals. And I would put some props out there for Deanne, one of our liaisons, who's worked many hours on this with a lot of different groups, and finally we're seeing some movement on that. So we have some place for our homeless population to go to if they do test positive. And we are also obviously reviewing a lot of plans and now re-reviewing plans because of the governor's announcement the other day. And they have been working with all of these community groups and businesses and even our agencies, state agencies or county and city agencies, to identify the best way we can hold activities or not in some cases. And just one number that I thought you might find interesting. We've tracked about 36,000 hours of staff time just in COVID response since January of this year. So that's not all of the hours. We do have a few stragglers who haven't reported all of their time in COVID, but I'm not going to name any names. There may be one or so in your meeting room there. I'll leave it at that. But we also have. What was that?
We'll talk later, Doug. I said we only have 2 to choose from.
Well, that's right. You can flip some coins.
Okay.
We also have some closed pod memorandums of understanding with several different agencies or organizations that we've done. Most of you, I think, are familiar with what a pod is. It's a point of dispensing for vaccine or immunizations. So one of the things that we've done is put together agreements with other companies or organizations to provide vaccine or immunizations directly to them so that they could provide those resources to their staff without our staff having to provide those. So we have about 10 of those in place already that cover probably almost, well, it would cover all of our healthcare system partners, a couple of county agencies, and at least one city organization as well in our district. So we're still working to identify more of those, but with these in mind, we could probably save a lot of work for our staff by providing these directly to an agency or an organization to provide the vaccines for themselves to their staff. So with that, I'd stand for any other questions or leave you to the rest of your meeting.
Okay, commissioners, any questions, comments?
Thank you.
Thank you.
Okay. Commissioner Marvin, we haven't heard from you for a long time. Just wanted to make sure you're still with us.
You're still awake.
I'm still here and awake.
Very good.
Well, two good things, man.
Yeah.
Hey, thank you. Just wanted to double check.
Punching him.
Okay. Was Jamie did she have anything for us? Or was it just
I think Doug could have it handled. Thank you.
Didn't quite get that.
Yeah, we're good to go.
Good to go, okay, all right. Okay, then, Executive Council update, Commissioner Dale.
There's not a whole lot to report. We did have a meeting, and it was one of the meetings we've had. It was all through the telephone, and what was it Zoom or GoToMeeting or something like that. I will say, though, that I was very encouraged because all 6 of the other districts said they would give money to District 3. Oh, good.
Okay, well.
Oh, did I misunderstand that?
I don't know if we were at the same meeting, but I hope I was at the wrong meeting. That was real sweet of them.
Yeah, I know. They just thought we were doing such a great job over here, they want to contribute.
Yeah, I'll bet.
Don't hold your breath on that.
Yeah.
We did, and.
But we weren't treated as a pariah,
What's
right?
that?
We weren't treated as a pariah?
No, we weren't, no.
Okay, very good.
Nick, you might want to jump in on some of this if there's some things. I don't have a whole lot. I do know that we did talk about the potential need to have a specific health district lobbyist, and there's some talk about whether or not we should do that because we're aware that, and I'm sure the rest of you have been aware of this, that there are some folks who want to bring up the health districts in the next legislative session to severely restrict or pull back, and some have even said dissolve. So it could be that we need somebody to really speak up on a professional basis in there. But that being said, I think the most effective voices in any lobbying effort of that sort are people just like you here, commissioners who are on the board. So anyway, Nikki, anything else that we need to talk about?
Maybe I could maybe just expand a little bit that Seth Grigg from IAC was pretty informative. He's had quite a few conversations, it sounds like, with legislators and other county commissioners too, around issues that may come up the upcoming legislative session, including funding for public health districts. And then, as you mentioned, governance, everything from governance. I've heard redistricting, although I didn't hear Seth say that on this last call, but he said it on previous calls. So, yeah, I think we just want to, the directors want, to be prepared for us to be a point of conversation at the upcoming session and have a good advocate for us at the legislature.
And a lot of that is just making sure we get the right information into their hands.
Right.
There's so much misinformation out there. And even from legislators from our district, he's from Canyon County, who wanted to propose limiting the authority of health districts to impose restrictions on schools. And nobody's ever done that. and yet it was an issue. Nobody in the entire state has ever done that.
Yeah.
I asked the question of that early on when we had the previous executive meeting, and nobody from any district said they'd ever put restrictions on schools.
Yeah, I think that's.
And yet that was an issue.
Yeah, I appreciate that. That is a really good point. And I've had a few legislators who I've at least appreciated have reached out to me and asked for information about our guidance or our recommendations or mandates, which then I'm able to, you know, address rather than kind of fuel that partial or bad information that they're getting. Yeah.
Well, most of all schools have a board. Their own board that they deal with.
Sure, and that's the thing, that's the message that I'm trying to put out there, is the school district have the authority through an elected board to determine what goes on in their school. And that's every school district in the state of Idaho has an elected board, and they determine policies and procedures and all that kind of stuff.
Yeah, but both the Nampa and the Middleton school boards have said that they're following our guidelines, so because of our guidelines, that's why they're not opening up. So you're right. Have a school board, they should be making their decisions without worrying about necessarily what.
They're asking for guidance, it's just guidance.
Right, they're asking us for input and data, guidance based on what, you know, we are seeing or what's happening. Yeah.
Anyway, so that's pretty much a statewide theme, and we're not the Lone Ranger here. Everybody throughout the state is experiencing these same issues, and I think, I don't know, is there comfort in company? I don't know. Not anymore. You got to stay 6 feet apart, right?
Right.
Yeah. Well.
You don't have to.
As for, I remember the one thing I was going to say is, and I know we've seen this in our district, and they've seen it in other districts where, and I just saw this last week at a place that I went into. Where was it? Anyway, it was a store. It was a store, and on the door was a thing. We are, because of the law that was passed, we are adhering to these restrictions and requiring you to wear a mask. So they're saying that there's been a law or an edict or a mandate, and that comes back to us because people think we did that, and yet we don't. So again, that's some misinformation that's being propagated out there by businesses, some of whom feel it more comfortable to blame somebody else for them putting restrictions on their store. And I will support a privately owned business to regulate however they feel they need to do in their own business. That's private property. If they say you can't come on our property without a mask, I'll support that to my death. That's their private property. Anyway, that's kind of the message that I try to put out there. And Nikki, anything else other than those are the big subjects really?
Yeah, I think that was it.
Okay. I just have one question or comment, whatever. You know, you mentioned that maybe having a liaison or someone to work for the health districts at the legislators, but honestly, don't we pay money to IAC?
Yes, and that did come up, and I think if I recall correctly, Commissioner Dale, one of the directors mentioned that, and I think what the discussion was is that Seth represents both the counties and the public health districts, but if they're not on the same page, which it sounds like there could be some counties that maybe would not be in agreement with where the public health districts are, that puts him in a really hard position.
Well, and the other thing, I think, good to clarify, the money that we pay to
IAC.
I don't know, I got city thing mixed up there for a minute, is mostly for monitoring issues. It's not a lobbying contract, and there's a big difference.
Yeah.
And that's why what we pay is pretty cheap comparatively to what you might pay for lobbying.
Right. I think we pay I think all the districts combined pay $10,000.
Yeah.
We all put in a little bit for.
I won't buy you a lobbyist.
No.
But a lobbyist is there for advocating for your causes and for your things. What IAC is doing for us is just monitoring legislation and bringing to our attention things that may concern the health district. They don't lobby.
She can lobby for us.
And that's what she doesn't like.
Good on you, girl.
Anyway, let's move on.
It sounds like. Okay. Is that all the information we need from you folks then?
That's all that's in my head.
Okay, great. All right, next on the agenda then is our COVID-19 health alert level update.
And I'm going to pass this on to Rachel in a moment. I hope she's on with us. But I did want to mention before she starts with her update that I asked our team to review our metrics that we're currently using to determine health alert levels, and as well as our mitigation strategies that we're currently recommending under each health alert level, because it's been several months since we adopted those. And because we are dealing with a new disease and data accuracy is important to us, I felt it important for the team to review that and provide any proposed changes to the board to consider today. So Rachel will provide an update on where we are looking in terms of disease spread in our community, but then also go over the summaries that are in your board binder today of proposed changes.
Okay.
Hello. Hi. So I'm going to go ahead and share my screen, and I will get started. You guys should have this document in your packets there. All right. So this is the document I'm talking about here, the summary of changes or proposed changes to the health alert level metrics and mitigation strategies. So I have this broken down.
Sorry, can you expand it just a little bit? So.
Oh, sure.
Magnification, yeah, thank you.
Is that better?
Here.
Yep, that's better.
Okay,
thank you.
Great. So I broke this down into 3 categories. The first is proposed new metrics, and then we have removed metrics, and then there's one metric that we'd like to edit the definition of. So I'll start with the new metrics. So we would like to start tracking the % of cases that have been interviewed by our investigations team. And this is intended to replace the average follow-up time for COVID investigations. And I'll speak to that a little bit later, but the % of cases that have been interviewed will give us, basically, it'll just be a better representation of what we were tracking with the follow-up time for investigations. We have new operations and policies with how our investigators are making contact and how those cases are assigned to our investigators. And that's kind of caused that metric to not really represent what we thought it was representing. And so we just would like to kind of switch those out from average follow-up time into % of cases that have been interviewed. And that's interviewed by the patient, a caregiver, a parent, anyone that can speak to, what sort of symptoms the patient's experiencing and things like that. The next new metric that we'd like to propose is local testing capacity information. This data has already been reported in our health alert levels. If you look at our dashboard, it's usually right underneath the positivity rate or in the healthcare industry input section. But I just wanted to give it kind of an official position. I think it's important to see how many testing facilities we have in a county, if any asymptomatic patients, if any places are testing asymptomatic individuals, what sort of tests are being offered. So that's just some information that as we go through these alert metrics, it comes up almost every week, and it's something that we talk about, and I think it's important information for the community to have as well. And then I'll come down to removed metrics. So the average follow-up time for COVID-19 investigations, as I mentioned previously, we have new operations where our administrative staff or data entry specialists will assign themselves cases and then reassign to an investigator, and they're kind of managing workloads in that regard. And so it's not really showing us actually the amount of time that it takes from reporting a positive lab result and then having the interview conducted. So that we just want to replace this metric with the percent of cases that have been interviewed. Our next removed metric would be, sorry, it's split there, percent of individuals that are diagnosed that were symptomatic. As Nikki mentioned, we're learning a lot about this disease, and the science is expanding, and we're learning new things. When this first all started, there was the estimation of 20% asymptomatic. Now we're thinking it's closer to 40%. There was recently a study published in the New England Journal of Medicine, and it had young, healthy adult males that were joining the Marine Corps, and they found that only 10% of the positive cases were actually symptomatic. So again, we don't really know what percentage of our patients should be symptomatic. So this isn't really representing what we thought it would. Additionally, what we're really starting to see with this metric is it's really just showing us when we have mass testing events. So for example, if a long-term care facility or a hospital is testing all of their employees, you're more likely to pick up some of those asymptomatic patients or cases, and that's where we're seeing the fluctuation in that metric, which isn't really what we were trying to track in the first place with that. And so hopefully with the information on testing capacity, and as we get more robust testing, we will start to see this metric becoming more solid in our understanding, as well as more representative of how many asymptomatic carriers there are in our district. And then onto our edited metrics. So we have the percent of cases with a known source, and we'd like to update this to be the percent of cases who have identified a potential exposure source. This has been a difficult metric for us. In the past, there was guidance from the CDC, which has recently been taken off of their website. So it's basically just referring back to the local health departments. So we've been in communication with some epidemiologists at Idaho Health and Welfare, and we've come up with this new definition of a known source. And so that's not necessarily only individuals who can identify a person and name that person, but people who maybe have a high-risk workplace, but they don't know exactly who it is at their workplace that infected them, or individuals who haven't done anything for a week, except for they went to one event and they got sick a few days later, so they're almost positive that they got sick at that event. So this is incorporating high-risk locations as well as group events where you don't know an individual that's infected you. Also, we are still tracking what we call an epi-link, which is where the patient can identify an individual person that they were infected from. And so we're just trying to kind of distinguish the difference between an epi-link and a known source. And so that's why we've included the potential exposure source phrasing in this. And so this is our new definition, which I don't know if it's relevant to you all. This is mostly for our investigators as they're interviewing cases to determine whether or not they have a known source or an epi-link, or it's a potential community spread. There is one part of this that I'd like to highlight, the declaring community spread and then renouncing community spread. Currently, we have declared community spread in almost all of our counties except for Adams County. And our definition there is if we have more than 10% of new COVID cases that have an unknown source. And again, we've seen that in almost all of our counties except for Adams County, which has had a minor outbreak, but almost everyone can identify where they were infected. So that's not indicative of community spread. And then we've also added this renouncing community spread, which hasn't quite come up just yet, but we wanted to have that definition available for us. And so eventually there will be a time where there is no more community spread in a county. And the definition for that will be a 2-week period, so 14 days, where all new COVID cases can be epi-linked. So that means that they know the individual and can identify an individual where they were infected. So whether that's a coworker, classmate, household member, things like that. or a friend where they can identify where they were infected or by who they were infected. And then lastly, we have the changes to mitigation strategies. I'm actually going to pull up our website for this. Oops. So on this tab here for our health alert level advisory system, we go down to this second image here. This is our mitigation strategies. The only proposals we made to this, and there's not a whole lot that we are proposing, is just removing this or, since we'd like to, in these alert levels, recommend all of these precautions and all of this guidance. And then additionally, for the red alert level, on this second to last metric here, or sorry, not metric, the second to last mitigation strategy, we'd like to recommend that all community members limit their participation in high-risk exposure activities. And again, this is a recommendation. There's no mandates here. And then if we go down to the orange category, this is where we'll recommend vulnerable populations to limit participation in high-risk activities. And that's just to help distinguish guidance in the red versus the orange category. And then just reinforcing that all of these different guidances and strategies are important in each of these levels. So that's all that I have to share with you all. Do you have any questions about the proposed changes?
Yes. Mr. Chair, thank you very much. Appreciate that, and I like these changes. I would just propose on your wording change that you eliminate both and or. There's no reason to put that and in there. You just here's the mitigation strategy. You don't need to put an and that for everyone. I eliminate the whole thing.
Okay.
Any
other questions?
Okay, good enough.
So I'm not seeing any downsides to doing any of this, is that correct? I move we accept.
Second.
Okay, I have a motion and a second. All in favor of accepting the changes to metrics and edited metrics, say aye.
Aye.
Aye. Okay, that motion carries.
Mr. Chair?
Yes,
I
ma'am.
have, and it's not a question about the metrics here, but we had an employee in Fayette County test positive about 3 weeks ago, and no one has contacted him. So does that mean their contact tracing is behind or not quite keeping up?
So if they tested positive, then we should be contacting them. And where we are right now, because of the number of cases that we're seeing, and this was a decision that was made statewide with the state epidemiology staff and the local public health districts, is we will contact somebody who's tested positive if we've gotten the result within 72 hours of the test. If we don't, then it's pretty much too late to go through the process of contact tracing at this point, and we don't have the resources because we're so overwhelmed with new cases to do the contact tracing. So we're asking people to do their own contact tracing, notify.
Okay, this individual, I thought he had a result for that, and no one has contacted him. But then the second part of that is, does that affect our rate of communication where he's not been contacted?
Right.
He's pretty sure he knows where he got it.
Yeah.
But he hasn't been sure that was right.
Yeah, I would say yes, although right now we have so much community spread. I mean, you've seen like my updates, it's pretty much, we can't really even tell where people are getting exposed right now. So to answer your question, I guess the other I can't speak specifically to that case because I don't know who it is, but we can look into it. We also, I know, try to contact, we were up until, that decision was just made, I think, on Monday, or late last week, actually, Thursday. So, and it sounds like he's been positive for a while. So they should have made an attempt to contact him. And if we don't have good contact information, or maybe he didn't answer our calls, so.
Pretty high profile,
Okay, okay. Well, maybe we can talk offline, and a little bit more information will help me investigate that.
All right.
Thank you, Commissioner Hannigan.
Kelly, did you have?
We saw the new employees. My question is, are there those new employees that were shown today, are they to add to the, or are they replacing?
Commissioner Abasteri, the employees that you met today that are new employees are actually filling vacancies of non-COVID positions. I think all of them. So right now we are trying to, we've had some of our really good COVID investigators that have been picked up for other permanent jobs, which is great for them because they're really great employees and will do well. And as you know, these are temporary jobs. So we are trying to refill those positions. We've also had some very early conversations with the National Guard to maybe see if there's some fit in getting some National Guard resources in just to help us until we can get more staff on site. And we're having a really hard time. We're trying to expand testing resources at our other satellite offices, and we cannot recruit a clinical trained person, and they don't have to be high level, but it's just really hard right now to recruit anybody that's in healthcare. So we're trying to maybe see if we can use them in that aspect as well. So I don't know if that really answered your question, but
well,
those.
Yeah, I was just looking at all the numbers.
I was curious too, wondering, wow,
So,
are we hiring that many people? And
you know, we have all these numbers looking at personnel costs and this and that. We know so much is going into for the COVID, and that's being funded by the federal government, our tax dollars. So, but if these positions that we're doing are to fill positions that we needed to fill, where are we at our capacity for internal? And where do we need to continue for COVID? I guess in the future, you know, in the next month or so, how many more people do we need to need for us to run as our normal?
Right.
And then how many more do we need for COVID?
Yeah, I think I hear what you're asking. So I don't know that I have an exact number, but I can tell you we are, as I mentioned to the board, I think for the last couple months, trying to transition to get all of our operations back up and running. And so some of those positions had been filled, but staff had been moved over to COVID, so we're trying to get them back. As I mentioned to Commissioner Elliott outside of the board meeting, but we've also had a lot of staff burnout and staff move on. So we've just like the staffing I mentioned that you met today, those are all staff filling vacancies for one reason or another. And so those, to get us fully staffed with non-COVID work, I would say most of our positions are now filled. I think we have a couple in environmental health that we're still working to recruit, and a planned retirement that's coming up in environmental health as well. So that's probably where we'll see the most hiring for our non-COVID work that still occur. In terms of our COVID positions, I mentioned we're trying to hire a few more investigators to fill vacancies, and we could probably use a couple more if things continue to go the way that they're going, or worse, which right now we're anticipating that they'll probably get worse through the end of the year. And testing capacity. I don't know what we're going to do about vaccines. We might have to pull clinic staff. Might be an opportunity where the National Guard could come in to help, or we might have to look at hiring some temporary staff for vaccines. And then operationally, we're hiring a program manager to take over the day-to-day operations, which Jamie and Doug were kind of sharing that responsibility as incident commanders. And as we talked about, we're moving that into a program manager position so that they can get back to the important work as division administrators. Long-winded answer, but hopefully I got it.
We need to move,
Yeah.
We still have many other things that need to be taken care of, that have nothing to do with COVID.
Right, yeah, I'm 100% in agreement.
It's definitely overrun us.
Yeah, it has, and I think we anticipated that to some degree. I don't think we anticipated the amount of time, staff time, for the length of time in this, and we've seen kind of ups and downs as things have, as the disease has changed over time.
As the virus has gone
Right.
up and down,
Yeah.
that's made a big difference.
Yeah.
Because there was a period of time in August when things were pretty low.
Yeah.
And then, with the weather and that more moisture in the air keeps everything more airborne. We're going to be causing, that's why we have flu this time of year.
Right.
Because of what happens outside.
Yeah. Commissioner Elliott, may I add something that a couple comments came up in public comment and then with some of the presentations by the doctors. And I just wanted to mention, I don't know if Rachel, it looks like she's still on, and I don't know if she'd want to pull it up, but we do have age data on our dashboard on our website. We also have the case mortality rate. So we don't have overall mortality rate because we don't feel comfortable that we know all of the asymptomatic cases that are occurring. And most of our testing has been pretty limited to symptomatic only. So we know that there's probably a lot of asymptomatic disease out there that we're not able to capture, but we have case mortality data, which the denominator is the confirmed cases in our community. We also have the case positivity rate that has the rate, but it also has the number of tests that are done each week, I believe. And that data helps, I think, address that question that came up. Well, you might have one person that tested positive out of 10 and then 100 out of 10,000, and there's it's the same percentage, but the number of tests differ. So I just wanted to say that, or share that we do have that information available on our website so people can be informed about who's being tested and what the positivity rate is in the community. And I don't think we have very good data on comorbidities, and partly because we don't have really good access to that data. Really, that's the only reason. It's just sometimes we get it and sometimes we don't, and we can't report it consistently. I wish we had it.
That can't go back to the death certificate? That data can't be mined to a death certificate?
It might be, but it would probably have to happen at Vital Records because we don't have access to all of the death certificates.
Because the comorbidity should be in the death certificate.
And so it should be. I know Dr. Roscoe has mentioned to us that sometimes the death record is not always completed in the most complete manner. So he said that can be a variable. And then the other thing is that not everybody dies. So if we wanted to capture that data across like those who are, say, just hospitalized, that we don't have really good access to that.
The reality is going to be the hospitalized patients are the ones who probably have COVID.
Right.
Not always, probably.
Yeah. So I just wanted to address that.
Chair, another comment I would make, 200 students positive in our entire 5 counties. That's pretty minuscule. 6 counties, sorry.
We still count.
Yeah, don't count yourself out up there just because you're far away.
I forget about you.
Yeah.
Just you. Just you.
The problem with that number is the kiddos are the ones who are most likely to be asymptomatic.
Right.
Right.
And so you're not testing them.
Yeah, but I'm still not understanding the asymptomatic part of it anyway. I mean, they're asymptomatic, they don't have symptoms. Are you sure the tests are all completely accurate?
Actually, in the people who are asymptomatic, if you catch somebody on early in the disease, so I'm exposed, don't have any symptoms, 3 days into the event, you stick a nose or swab up my nose, it's probably more likely to be positive than 2 weeks from now. And so that's, the asymptomatic is probably your prime time to check. If it's most likely to be positive if it is positive. Because that's when you have the highest viral load.
I still get that, but it doesn't make any sense to me that we want to lock down everybody because they're asymptomatic. Are they, I mean.
That's when they're most infectious.
To who? Because there's only 200 kids that have it in all the schools.
But those are the symptomatic kids. How many asymptomatic kids are out there spreading the disease? And frankly, it's not the kids that I'm worried about. I mean, there's a few kids that really get sick with the missy thing, but it's the teachers.
Well, what about the flu? I mean, are we just going to continue this for everything because people die of the flu?
Not at this
They get
number.
pneumonia.
Not at this number. And we have treatments for flu. We've got remedies that actually treat the flu.
Well, there are remedies for this.
And we got immunization.
Okay.
Chairman Ellis.
Yes,
Sorry to interrupt you. Before you move on, I need clarification on the vote, please, to remove the edits to the mitigation strategy.
Yes.
Typically, you ask both sides to go through in favor and opposed. And I just
okay,
all of them.
you are correct.
Thank you very much.
You are correct, and I thought it was unanimous, so.
I know,
I should have.
I didn't vote, I'm abstaining, because
Okay,
I don't think we've had enough time to really look them over.
Okay.
So I didn't.
Then that was my bad.
Well, I
should go back up, and I will ask if there was any nay votes for that.
I didn't vote nay, I just didn't vote, because I don't have,
So an
I don't
abstention
need
then.
more time to look them over, I want to sure read it.
Okay, very good.
Perfect. That helps me note that one abstained. Often,
All right.
I type it,
Thank you for that.
But I was under the understanding that we're gonna be constantly monitoring these metrics that we're doing. Is that correct?
Sorry, Commissioner Abstrait, can you repeat your question?
Louder, please.
I was under the understanding that we were going to be constantly monitoring what we're doing with these metrics and change them as needed. Or just quit using ones or whatever. Is that correct?
Yes, so that's why we brought them to propose.
That's what I thought.
Yes.
Thank you.
Okay, is there any more questions on that before we move on to the director's report? Or comments?
Hey,
You were gonna move to adjourn, right?
I know it.
I'll cut my agenda items in half. How's that?
Just giving you a hard
Some of them can be rolled over. And they're really just quick announcements. One is, the Public Health Symposium that we were gonna hold today, we've rescheduled to December 8th, and it will be, online. And the reason for that is just what's kind of happening right now, plus, our staff are just kind of getting overloaded. We need a little bit more time to prepare. So I hope you can join us for that virtual symposium. More information will be coming on that.
December 8th?
Yes, December 8th,
Come through on that.
10:30 to noon.
Yeah.
And then I just wanted to make a note, our agenda says our December 15th meeting starts at 9 a.m. It actually starts at 10 a.m. next December, and then, not next December, this December. And then the rest of my items can be carried over till next.
Are you sure?
Yes.
Okay, I don't want to cut you off. I didn't cut anybody else off.
Yeah, we got.
Okay, I'm cutting myself off.
Okay.
They're not important.
So the cow was after like 4 or 5 hours.
Okay, Kelly, I was.
Crazy, and then just sell it.
I'm ready. I'd make that as a motion.
Okay, I have a motion, do I have a second? Okay, all in favor say aye. We are adjourned. Thank you.